and wish you all the best. So 3 spotters will be there for each team. The first spotter for the team 1, that is AIMS Bhuvaneshwar. Introduce yourselves. Anish Gangoli and Vidish Kumar.
Good evening.
Vidish Kumar.
Good evening, ma'am. Good evening to all the respective members.
Yeah. So the panelists, all next first spotter. Yes. First spotter, please. Yeah. The lead panelists are Dr. Vinita Puri and Dr. Durga Karki. I invite them to start their questionnaire. And 10 minutes will be for a discussion. And later, 5 minutes, they will answer which are the unanswered questions of both teams. Srivalli, kindly maintain the time and tell us. Dr. Vinita ji and Dr. Durga ji. Hello.
Sorry. Okay. If you get a patient, the way you see on the left side, right? So what are the specific things that you would like to examine in this patient?
Ma'am, first,
Specific features that you want to examine.
ma'am, first we'd like to see the condition of the airway, ma'am. What are the how is the airway pattern, ma'am? If he requires and we look for signs of inhalational injury, ma'am.
And that would be?
Ma'am, it will be stitching of nasal hair, stitching of the eyebrows, soot particles in the face, oral cavity, and frontal hair singeing, ma'am. Then general consciousness of the patient.
As time goes by in a patient like this, you're seeing the photograph of this patient. What would we be worried about?
Ma'am, they will airway can become compromised, ma'am, because of the edema, the laryngeal edema, ma'am. So we have to first be careful and try to secure the airway by intubating,
How
ma'am.
would we recognize that the airway is getting compromised?
Ma'am, the breathing
Hello,
pattern.
कौन है गलत तो
Can you change the voice, ma'am? Any hoarseness of voice that is reported? And
Yeah, I know, I can hear the voice. Can one of the admins maybe okay. Gone on mute. Fine. So how will you clinically recognize?
any hoarseness in voice or change in the voice that is reported by the patient, and any stridor or difficulty in breathing can be a sign of impending inhalation injury.
All right. Durga, you want to ask something?
Durga?
How will you? Okay, I'll ask. I'll continue.
I'll ask. I was mute.
Okay.
I'm asking, is there something important in the history you want to like to ask the patient attendant for these types of patients?
Ma'am, we'll like to ask, we'll like to find out what was the cause of the burn, ma'am. And what was the cause of the burn, then for how long the contact with the agent has been, ma'am.
Like cause means it's something more specific.
Ma'am, is it like due to the, is it as it happened in the closed room, whether we can, then or it has been happening in an open space? Has it been near to the,
Okay, anything more? If you are very much, worried about the airway, anything more to rule out? Second team too? Hello? Team 2?
Team 2, Gandhi Medical
Okay.
College.
Did the incident happen in any closed space? Are they exposed to any
That is
explosion?
already been told by the team 1.
uh, or any particular chemical agent which was inhaled if it was in a factory or
Yes, yes. Then how you proceed with this patient, like if it comes in the casualty or in your emergency?
One.
we have.
This is for team 1.
Team 1.
Okay.
Ma'am, first we'll proceed to
You
secure
have
the
secured the airway as you told already.
Yeah.
Then after that,
cervical spine stabilization, ma'am. Followed by which we'll assess the breathing, ma'am, and we'll give him oxygen because we'll give him oxygen, full 100% oxygen, and then after that we'll secure 2 wide bore IV cannulas and start the patient on IV fluids, ma'am. And then see circulation, and then we'll assess. Then after that, we'll assess the GCS, GCS of the patient, and
your time is passing. Just give the salient points.
Specific,
What all you
yeah. Specific points.
Once we've secured the airway, we'll start the fluid resuscitation, catheterize the patient, and plan for dressing and admission into a burn center.
So when you say dressing, what would you like to do? What will be the next thing? How will you manage the burn?
ma'am, because it's the facial burns, ma'am, we'd like to clean it with the saline, ma'am, and then we'll try to like to put a collagen dressing, ma'am, over the face.
All right. After that,
In this patient, because he'll be intubated, and we'll also start him on steroids for prophylactically.
Is there any role of prophylactic steroid in these patients? And if yes, what is their role?
Ma'am, as in our institute, we are giving IV prophylactic steroids to such patients, ma'am, for to counter any laryngeal edema which might happen. So for that purpose, we are giving, ma'am.
Okay, then after that, after the dressing, what you will do? In every patient, there is a requirement of intubation in these type of patients. In every patient, you will go for the intubation.
Ma'am, if we are seeing signs of inhalational injury, then in our
What are the signs of inhalational injuries? I mean, clinical or something more?
ma'am, clinically, the signs of inhalational injury will be
Stridor and with this
hoarseness of voice, ma'am.
hoarseness, you will do intubation in every patient.
Soot, if we see some soot particles in the oropharynx on inspection, and if we see soot particles in the nasal region, we'll prophylactically will proceed for intubation,
In
ma'am.
every patient. Say yes or no.
Yes, ma'am.
for every patient. Okay. So now, let us say that your first 48 hours has gone by. You have not really intubated the patient, and the patient has had such facial burns, right? Do you have an idea whether you are now safe from your pulmonary burn component and you have to take care of only the skin wounds, or you would need to look out for something in the future too?
No, ma'am. After 48 hours, we'll have to look out for, we'll be looking out for signs of ARDS in the patient, ma'am.
Specifically ARDS, why?
Pneumonia, you can have pneumonia, ma'am.
So that is specifically related to the fact that this
Yes.
patient has pulmonary burns, or any which way you would be doing that for any patient with a higher percentage of burn.
With all patients of burns, ma'am.
All right.
But
Because
So
these
I'm
are the
asking
late
very
features.
specific. Yeah, yes.
These are the late features, pneumonia and atelectasis. These are the late features
But
after 3 days or so.
in a patient who has, let us say, a pulmonary burn, what are the, when you say pulmonary burns, do you have any idea of what kind of burns happen? What is the level of the burn? And what are the effects of that?
Burns can be at the level of supraglottis or at the level of subglottis.
Okay.
If it is going
And if it is lower, then what happens? What is the pathophysiology that happens?
the oxygen, not sure.
The team 2 wants to answer this.
Involvement of parenchyma, ma'am.
Is it because of the heat?
It is because of the steam and hot air gases. Then the supraglottic airway gets involved. If it is because of the chemical particles and the soot which gets inhaled into the lung, then we see the
Yes.
parenchymal damage.
Yes. Okay, fine. So let's say you have applied collagen. How are you going to manage the actual burn of the face?
Ma'am, initially after stabilizing the patient, we'll first have a second look and see how the
When will you do a second look? You have applied collagen, right? Right. Now
Ma'am,
what?
time, sir.
Time up?
Yes, ma'am.
Okay. Lakshmi, we can't hear you. You are muted.
Muted.
Any unanswered questions to be answered by the panelist, we should answer here, or you can continue these 5 minutes asking questions.
So we'll Durga, do you want to ask more questions?
I'll ask one thing. I mean,
Yeah,
I'll just
yeah.
add one thing because, if we are going with the inhalational one, very important to have we have to see whether it is a direct thermal injury or due to the inhalation of the chemical irritant.
Right.
And third is the systemic, effect of these toxins. So we have to look all these three. Like as soon as patient come, intubation is not the only answer. We have to go through all these things, and which is very important in this airway, very important. We have to resuscitation a little bit of more fluid which is required in these patients as compared to the normal patients without the inhalation. So we have to take care of all these things. And important is we have to take the history, some blast occurs, some closed space, which is very important, how the mechanism of injury is there. So I want to, add this, whether the plastic burn or some wooden clothing, so we can have some idea regarding some systemic effect we can see with the toxic gases. So these are very important, to ask the questions.
So
Yes,
clinically,
ma'am.
like she said, clinically, it could be possible that you may not have that much of excessive edema in the upper airway, but somewhere at day 5 or day 6, because there is a lot of alveolar damage also that happens because of the chemicals, there will be, they start sloughing inside, and that's when you will have a problem. So you can't just tell that in general, you can't just say ARDS, but you have to understand what is the pathology that's happening behind and keep an eye out for it. And when you say collagen, you also have to say that you will first clean the dead tissue, remove all the dead skin, and then apply the collagen. And beyond that, after that, you also have to say what will happen. It is like, it is not essential that everything is going to heal the depth of burn. So ideally, you should have gone down that path also from a wound management point of view. Wound management does not get over with just application of collagen, but further to that, what happens?
And one important thing is that in the investigation, if you are suspecting an inhalation, very important to go, once the patient is little bit stabilized, flexible fiber optic bronchoscopy. That is a very important, parameter to see, how much is though it is only with the little bit of we cannot judge the parenchyma which is involved, but still the bronchus and the proximal area which is involved to confirm, it's a inhalational burns and various important features which are there. So we have to go with this investigation once little bit patient is stabilized. So these are the important things, and in each and every patient, we cannot, like intubate with a facial burn. We cannot, patient may be having some singeing or it's only a, thermal effect on the superficial area. So this is very important, which patients are to be intubated and which to be progressively we have to see. And doing a chest X-ray, ABG, though they are not very much disturbed in the initial phases, but we have a parameter, at least a basic baseline is there. So we have to go with these important things.
We have 2 minutes more. Do we, Lakshmi? We can't see the time. I just wanted to ask them one last question. Is there any difference between the facial skin from wound management point of view as compared to other areas?
The face has very good vascular supply, ma'am. So the healing over the face is faster, ma'am, and better.
Okay, fine. You want to give us the next one?
The
What time is
moderator
there?
will,
One more minute is left.
Acha. Regarding the pathophysiology, you are not very sure, very specific pathophysiology with the inhalational burns. What happens is that when there is a, damage to the airways, so there is a permeability increases, secretion increases, and there is a formation of these cast, fibrocellular cast, which plugs the alveoli and, distal airways, which is very important. So later patient develop atelectasis, pneumonias. These are the late features. So pathophysiology of inhalational and the thermal, if it is only the facial, these are very important, very unpredictable, prognosis in these patients. So we have to take care of all these. In these cases, the ventilation is also different. That is taken care by the anesthetist. But these are the salient, feature in the pathophysiology of inhalational burns.
Do you want to take any other consultations? Other departments?
Yes, sir. We'd like to have a ophthalmic checkup done, sir. And
Did
also,
you tell that?
sir?
Did you tell that?
No,
Sorry to
sir.
interrupt, sir. The time, sir.
Okay.
let PG's answer because next is the moderator. Sir, answer the question. So ophthalmic consultation need to be taken.
Yes.
Dr. Bhattacharya, sir.
Yeah, I'd just
Any
like to
question, sir?
question is that what is the importance of the time lapse between the occurrence of burn and the shifting of the patient? How long the patient was in that atmosphere? Is it important?
Yes, sir. The duration is important, sir, because that will give us a idea of how much exposure has been there for the patient, sir. If it is,
Especially, sir, if the
Okay.
patient is in a close
If
space.
you see the hairs of the patient, does it indicate you something?
sir, this hair, sir.
Condition of the hairs, scalp hairs.
Yeah.
You look at it carefully. Does it indicate anything?
There is singeing of the anterior hairline, sir. There is singeing of the hair over the anterior hairline.
No, not only anterior hairline. You see the whole hair. They're all burned.
Mm.
So that gives an idea about the duration also.
More than-
You see that?
Yes, sir.
It's totally like.
On the left side.
And again, you see the right ear.
Yes.
Right ear helical rim is having deep burn.
Good one.
So when the cartilage gets a deep burn, obviously the adjacent facial area and the eye areas are bound to have deeper burn. So initial assessment of the burn, this helps when you look at the ear or the nose, wherever there is cartilage. That's it.
Okay. I invite Dr. Venkatratnam.
Can I have
sir.
a question, sir?
Yes, sir.
Well, in inhalation or respiratory burns, what is the ideal time if there is a laryngeal spasm going to happen and you want to intubate?
Within 48 hours, sir.
Ideal time, because ultimately anesthesia will not be available 24 hours. So you have to assess the patient and tell, yes, I need to have a intubation or I have to have a tracheostomy. Because most of the patients, they die of the inhalation or respiratory burns in most of the accidents that happen. What is the ideal time?
Within 48 hours, sir.
No. By that time, you can't do anything.
6 to 12 hours. 6 to 12 hours.
No, that is also too late. anything between 4 to 6 hours. Because once there is a laryngeal edema and there is a bronchospasm, you cannot intubate.
Right.
Then you have to go for the other procedure. Okay, that's all.
I invite Dr. Venkatratnam, sir.
Nothing particular. Let them go ahead.
Okay. Judges, any one of the judges would like to ask questions to teams? Any seniors in the attendance, like other panelists would like to ask any questions to the teams? Anjana? Dr. Anjana?
I just want to ask one thing. How does the inhalation injury change the prognosis of a burns? The patient with a similar percentage of burns, one has inhalation, the other doesn't.
Team 1.
Ma'am, it will
Team 1, answer the question.
it will double the risk of mortalities, ma'am. Risk of inhalational injury. It will increase the chances of mortality for the patient.
By how much?
To
Or more than that.
modified box score. 17 we are multiplying.
Team 2, do you want to answer this?
80 to 90% increase in the mortality rate compared to the thermal burns if it is associated along with inhalational burns.
No, it's not 80 to 90%, but there is a 7-fold increase in the mortality percentage to percentage if you have a full inhalation injury.
Dr. Bajaj, sir?
Well, first of all, I just want to ask you, what type of burn is this? Burn is confined only to the face. Clear cut, they know other side of the burn. Then why we think about in terms of inhalation injury? This injury can happen on the case of stream injury. You opened up the lid of a cooker or something, or in the case of chemical burn. Now, in this patient, we are not seeing any froth coming from the mouth. Therefore, clear cut, there is no injury to the mouth and airway, the other thing. Therefore, there is no question of going and thinking in terms of inhalation injury. We are seeing on the eyelids are closed. There were no burns on the upper or lower eyelid in this case we are seeing. In the second slide, we have to be, this burns are confined only to the face. Therefore, this burn is more or less 2 or 3%. There are no burns on the back. Hardly any singing of the hair, which Dr. Bhattacharya said. If you keep on seeing the layer on upper limit on the second slide, there's hardly any burn on the forehead. Just a small burns are on the forehead. So therefore, the question of thinking in terms of, if suppose the burns are, you are in a close confinement other situation, then you can think of. But here the burns are only confined to the face. So you have to think in the term. And there are no frothy secretions coming from, or there nothing burns on the upper mucous membrane. So therefore, there is no question of thinking in that way. And now the second question which was asked, that we will put down the IV line other situation. Now there are only 2 or 3% burns are there. So what you need it, yes, you will have IV line if any problem comes down there. Yes, you will think in terms of the intubation or the situation, but there is nothing. You can't see any soot particles on the upper lid, on the lips. You are not seeing any froth coming from the mouth, which denote that the mucous membrane is burned. So therefore, in all probability, this is a very simple burn. It may be anything, but you have to be a little bit of those think in that terms. Only 2 conditions can cause this type of a burn. Either very short flame burns, you come in contact and you're away from that. The most commonly, these are the steam injuries, which comes down to the opening of the boiler or other situations.
Sir, in second case also, you feel there is no inhalation burns or the respiratory burns because the aloe and the hair singeing is there in second case.
In the second one,
yes, sir.
you see the half of the forehead is non-burnt.
Yes, sir. That is not
Here,
burn.
half of the forehead.
But
So these
peri-alar region
no,
looks a
now
little, yes, sir.
these two slides show the
Yes, sir.
burns are only the face. In one, you have got some extent coming on the neck and beyond. It means these burns are taken place with the face extended, neck extended. While in other case, where the very small portion of the neck is burnt, and this is happening mostly in case the neck was slightly flexed. That's the only thing is there. Rest is all because it's not nicely clean, not nicely done. That's the only difference is there. Now, if you just see in the first slide, at the globular region, there's no burn.
Yes.
There's no burn on the upper eyelid on both the sides. It means the eyelids are mostly, face are mostly closed. Suddenly, something has happened, and therefore these situations are coming up. Now, you have to think in terms of in the inhalation injury, if you are in a close confinement. When you are close confinement, the burns will be extensive. Other part of the body will also burn. This happen only if sudden flash of steam has come up, or suddenly somebody has put on some acid or some other situation down there.
Sir, can scalds or steam, what sir you are telling, can cause these inhalation component of the burn?
Basic
steam is
inhalation
there.
component you will see in all cases in inhalation injury that the mucous membrane starts secreting when the burns happen to mucus. Lot of froth start coming down. Soot particles you will see. Nothing is seen in this case.
But history is very
I
important.
mean to
sir.
say, if the scald is there, or what sir you are telling that there's a pressure cooker you want to see, or there's a steam is coming out, it can cause inhalation component.
In that case, it can happen for sure. But first thing which you'll see in all these conditions, that you will see the mucous membrane burnt. Now, in body, there is a complete phenomenon where once you take the hot air inside, by the time it reaches to the trachea, they all cool down dramatically. Only thing comes out when you have got this situation taking place more than a minute.
Yes.
Now, all these things have taken place probably in more few seconds only. They come in contact and gone. Now, these are the basic you have to put it on. Now, Dr. Bhattacharya put it down on the ear cartilage. Now, remember whenever the injury happens, because the ears are out, so therefore maximum brunt will come on the ear. The contact in that case will be slightly longer because of the curvilinear surface down there. Therefore, hot steam will remain there for a little longer period of time. But at the same time, we are not seeing same effect on the tip of the nose, on the L of the nose, and all these conditions. Had it been darker, then immediately we'll see the depression coming up in the skin when the burns are full thickness or other situation. That start digging down surface, you will see the non-surface other complete demarcating line coming up. Nothing is seen in these cases. This can happen. You should be well prepared. I totally agree with all of you. It can happen. You should be well prepared for all the situations.
So sometimes in the factory, when there is a blast of boiler or something like that with the hot steam, which suddenly with that injury, then that is usually associated with the inhalation, though they have a very localized area, maybe the skip lesions, any other part of the body. So that may be the cause where it's a little bit localized to the upper part.
Upper airway.
Durga, you are perfectly right. The point you have to remember, we are teaching to our boys how much you should try to see the situation.
Yeah,
now,
clinically very important to differentiate, what all points in favor and against.
Listen to in the case of boiler injuries, if you remain there in the boiler for a little longer period of time, you will see burns on the shoulder or the other aspect. Here you can see confining to the face. In both these slides, in one you will see upper part of the chest is slightly burnt and neck, which means the burns have taken place in the extended position. When the first slide you are seeing the very small burnt on the neck. Again, this is basically in the in this. Now, if you say that about hairs, which you said it, I can't say singing of the hairs so much. But if you are seeing singing of the hairs is there, it means they are flame burns. It means the electrical flash burn or some of those situations where you see very high energy for very short period of time, fraction of a second, in the electrical flash burns.
I just wanted to make a point that the right-hand side picture is of a burn which has occurred few days back. And there, if we see the mucosa of the lips, they're absolutely dark and as if they're very hard.
Yes.
At the same time, if you see the center of the neck, it seems to be that it is definitely going to be a deep burn because they're absolutely, you can see it.
Vishweshwar,
Sir, just a minute, sir. On the contrary, on the left-hand side, it looks to be a more fresh burn, and the changes in the mucosa takes little time. On the day of observation, first day, second day, third day, it progresses. Maybe that in the first day observation, it looks like this. If it is really deep, it will take little more time. The lip to appear differently, say after 2 to 3 days. So these two pictures are not exactly in the same time of burn. This may be after right one, maybe after 2 weeks after burn, and the other one is within say 48 hours. So these two are not comparable as far as the depth of burn is concerned. The right answer is definitely going to be deep on the lip as well as in the center of the neck. Eyes are spared perhaps in both the cases.
The discussion is very long, but I think we are short of time.
Yes,
Very long topic.
yes.
Please go
But
ahead.
definitely we have to take into consideration regarding the history because recently we have seen the one case, no burns at all in the face, but she had the respiratory problem. It happened near the patient was just adjacent to the blast, cracker shop blast. So that inhalation component definitely we should exclude when there is a facial burn. I think it is accepted by all the panelists and moderators and seniors. We always should keep the mind in the regarding the inhalation burns especially when the facial burns are there. And because we have to ventilate early and intubate early. So sometimes the time will not be allowed to intubate if time lapses beyond 7 or 8 hours if glottic edema is there. So we should be prepared for tracheostomy in those conditions. So everything should be kept ready.
I think we should go to the next.
So that is the main purpose. Yes, sir.
Now we can go to the next.
It's very difficult to do tracheostomy also in such cases. Recently we faced this problem.
Sir,
So,
one question. Lakshmi.
Very. Sir.
Lakshmi, one question. Who is in favor of admission? Who is not in favor of admission? And why? The students I'm asking. Admission. Will you admit the patient or not? And why?
Team 1, team 2. Tell yes, no.
Yes, sir.
Yes, sir.
Yes. Sir, right answer.
Both are yes.
Facial burns always critical burns.
Everybody will agree with that.
So we'll go to the next spotter, please. Next spotter. Yeah. The panelists, lead panelists are Dr. Anjana Malhotra and Dr. Umar.
What's your diagnosis?
Dr. Anjana?
Yeah. Is
Postpartum
it? Yeah. He has asked, Dr. Umar has asked you, what's your diagnosis?
a postburn contracture involving the anterior axillary fold on the left side and the elbow.
See it in greater detail.
With the hypertrophic scar present over the anterior chest wall and scarring over the left side of the face, leading to ectropion of the lower eyelid.
What about the nipple position?
It's distorted due to the scar, pulled downwards.
So it's extending right across the chest wall also, the linear scar, isn't it? So,
do you expect the burn? Why do you expect the burn in the limb with a contracture like this? extending from all along the forearm, if you can see the band, to the chest wall across axilla.
So the burn possibly affected the anterior chest wall, the axillary fold, and the elbow.
Is it chest only?
Even the left side of the face, sir.
And confined to chest?
And the upper part of the abdomen.
That's why you didn't tell that.
So your examination should be full, no? You have to see, take some time, few seconds.
Will it make a difference to include abdomen or not? Percentage of burns.
Yes, sir.
Calculate.
Percentage of burns we have to include. Will change if the abdomen is also affected.
Yes.
So how much do you think the acute burns the percentage was as per your description now?
Ma'am, we can use the London Browder chart for the calculation of the burns area, considering the age of the child. This is
4 plus 3.
Give a figure, not the theory.
Sir?
Give a figure. What is the percentage?
This is
Around 25 to 30%,
25%.
sir.
Really?
Okay, so what do you
Hey,
think the problems the child has now?
The child here is presenting with a hypertrophic scar over the chest wall and the anterior part of the abdomen, a contracture shifting movement over the anterior axillary fold and elbow.
So
What
what
would
will
you?
be,
Yes, ma'am, continue.
yeah, what will be your plan of management for this child?
Ma'am, as can be seen in the picture, only the anterior axillary fold is involved. The dome and the posterior axillary fold seem to be okay and not involved in the contracture. We can go for a multiple Z-plasty release, or we can go for a release and STSG for the contracture.
No, you'll do nothing for the elbow? Or you'll do it secondarily? What is, I mean, the plan has to be complete, no? This child is in front of you.
We can, ma'am, since the splinting would be, we can release both the elbow and the axilla together, provided we counsel the patient preoperatively regarding the splinting and the position of the limb postoperatively.
How will
Yeah,
you plan?
you can see that same band is extending across from the axilla, across the elbow up to the wrist joint, isn't it? So I do not think you can just
Anjana,
release one and leave the rest.
If you feel the answer can be given a better way, you can ask. So ask the question. If team 1 doesn't answer satisfactorily to you, you can pass on to the team 2.
Okay.
Which part of the body would you again want to examine? If you plan to release now the contracture of the elbow and axilla, do you want like to examine something else in this child?
Yes.
Team 1.
See, we also want to.
And along with it, we'll also like to examine the hand, sir. Not.
Hand seems normal. If you can see the first picture also on the extreme left. I mean to say, how much graft will you need? How can you calculate?
We'd want to examine the opposite side, the normal side, to assess the true defect, and then the donor site area so that adequate graft can be harvested from.
How will you do that?
So we will mark the true defect for this patient can be marked by measuring the bony landmarks on either side. We can take the mid-humeral point on the normal side and the ulnar styloid process and take the length and mark it as the true defect on the affected side. That is the amount of graft that we will require to harvest from the thigh, which can be a donor area.
What is the extent of the contraction? It is extended up to the elbow only, up to the styloid process only. It is extended from where? From the wrist.
Axillary fold up to the wrist, sir.
It is extended from the wrist across elbow up
Yes,
to.
sir. Up to the anterior axillary fold, sir.
So the landmarks did you take?
The
was
acromion
correct?
process.
So, yeah, team 2, you can answer if
Ma'am, we can take the landmarks of the acromion process, mid-humeral point, and humeral condyle, and also the wrist joint, and completely mark how much true defect would be attained after release of the linear band.
Actually, you have to separately see how much you need for release of the axilla. Isn't it? Isn't it?
Yes, sir.
Then again
But
for the elbow.
you have to do it as Dr. Umar is telling you in 2 parts, isn't because it's a double contracture.
That will be a better way. Right?
So you would like to assess a single one first and after releasing the second one, or simultaneously. So those things you have to plan, isn't it?
Could you classify the axillary contractures?
Axillary,
1.
axillary contractures is classified by Kurtzman, where type class 1 is where anterior axillary fold is involved. 2 is where posterior axillary fold is involved, and 3 is where both anterior, posterior, and the dome of the axilla is involved.
Okay.
One.
Proceed for the management, Anjana. Time is there, not there.
Now, how will you proceed?
So since this is a single band extending from the axilla to across the anterior axillary fold and the elbow, we would want to release it. We can do an incisional release and multiple Z-plasty across the axilla, and release across the elbow with intermediate thickness split thickness skin grafting.
Would you like to do something for face?
So for the ectropion release, we can do a Z-plasty or a scar revision across the face as well on the left side of the cheek.
Ectropion Z-plasty. Why will you make the Z?
To break the scar, sir. Since this is a contracture, just to break the contracture, we can do a Z-plasty.
For ectropion? Why?
Or we can do a release in FTSG. An incisional release and a full thickness skin graft can be harvested and with ectropion, sir.
You said
The lower lid.
Z-plastic?
What do you normally do for the lid? Do you put a FTG or STSG?
Sir,
In your unit, what are you putting? If you release an ectropion,
we're putting
practically, what are you putting in on release of the ectropion?
FTSG, sir, a full thickness skin graft.
Release from? Where do you get it from?
From the groin.
What is the advantage and disadvantage of this?
So a full thickness skin graft, the advantages would be that since this is a child, the graft would be a better contour and would grow with the child. The disadvantage would be a limited amount of graft that can be harvested from the groin region, and the take of
limited means what? How much graft do you need here? You need a big graft. If you have an ectropion, you need a so much big graft that you cannot get from the groin.
No, sir.
If it is upper lid, you will again put the FTG.
Panelist,
Time allotted.
you
Time
would like
allotted the
to
previous slide is over.
Yes,
explain the panelist, try to explain them now how to address this case. From your side, you please give your inputs. Anjana?
Yeah.
Yes, ma'am. You want
So,
to start?
yeah, okay. So, can we get the pictures back
Picture
on
back.
the
Picture back
screen?
on the screen.
So that
Shivali, go back to the previous slide, please.
Yeah.
So actually, as this we were telling you in the beginning, this is one contracture extending right from the wrist across the elbow into the across the anterior axillary fold up to the breast. And when you see the with the hand down, the both the nipples are the same level. But when the patient is raising his hand, this nipple is getting raised across along with the contracture band. So basically, once you release this, you will create raw areas all across. So you have to plan for release of both the axilla and the elbow. So in the axilla, what your plan was correct that you, because this is a linear contracture, the skin is good on both sides. The dome is not affected. So you can go for multiple Z-plasties. But there are two things you have to take care when you're doing the Z-plasties. One, that your Z-plasty, the first Z-plasty has to get the nipple down to the right position. It has to match this with the hand raised. Okay. And the second is that your Z-plasty should not disturb the dome, and it should not disturb the axillary hair. So there is another, square flap, which is very useful in axillary contractures. And I think, I don't think those slides are here, which were marked. You give a square and then you give two Z, one at 90 and one at across this at 90 and 120 degrees. And the square flap moves into the Z, which opens up. So the square flap is on this side and the Z is on this side, and it opens up. And then after this, after you have released the axilla, completed all the Z-plasties here, you will be still left with this band across the elbow. So in the elbow, I think, I don't know if most of you may have heard of it, what is known as an X-plasty. You keep a strip of skin across the joint, which is made of this contracture skin, so that you have the normal skin across the joint, and on both sides, once you cut it as an X, you will get two diamond-shaped defects above and below, which will then be skin grafted. Okay. Dr. Omar, you want to add something?
No, it is all right, ma'am. Just touching the ectropion, you said rightly that will actually ectropion I cannot see any Z plastic can be done for the ectropion release. You have to simply release the ectropion and add a graft, and you said that we'll harvest it from the groin, but I would not prefer groin. Secondly, for the upper, if it was upper lid ectropion, right? Then the choice here is not, usually it is not the full thickness graft. If you want to do a full thickness, and it is documented that you have to take it from the opposite eyelid, what the books say. But usually we put the split thickness skin graft on the upper eyelid ectropion, and the lower FTG will do. That I want to add. Right, as rest the madam is covered very nicely.
Plastiquest.
Anything you want to ask? If you have some, you want to ask.
Other two panelists, if they want to ask any question.
Yeah, I want to make it clear that, in these type of patients, because this band is not very clear whether it is a extrinsic contracture or the intrinsic near the axilla. So very important to rule out that it's a portion is extrinsic or intrinsic. So once you release the chest one, maybe that, majority of the axilla wound is, released without giving a incision, because in this, I'm not sure about the scar. So once you release the axilla, then only I think elbow part is quite, taken care with this release. So you have to very careful regarding the what is if there any portion of extrinsic or intrinsic. Rest is covered by the panelist.
Again, if you see the first picture, it seems there is some normal tissue, normal skin in between. If you see the first picture, extreme left, there is a band across from the wrist up to the mid arm. Then the skin seems normal medially. So maybe these are the two contractures. Seems below the skin in the axillary contracture which we are seeing may be normal behind also. So
Yeah,
the
that's why
pull
I'm
is
saying.
from the abdominal scar, maybe here.
Yes,
Not clear.
definitely in a child with this type of contractures, mostly the children will be sustained with the skull burns. So maybe a little second degree or deep second degree and heal like this. Always when you see this type of web-like contractures, you have to check the normal skin and the feasibility of the local flaps first and release one by one and assess the remaining thing and plan again. So minimize the grafting
Requirement.
in these cases because it's like a web, it itself can provide the flap. So always you think surrounding normal skin and the suppleness of the scar, it will support the release and cover the area, and only the remaining things can be grafted. I invite the moderator, Dr. Bhattacharya sir, to give the comments.
Yes, this is to the team, which is number one, is that if you come to an important observation, when the position of the arm is near the chest, the bands disappear, becomes much less prominent. Number one, why? Number two, if it is so, as it is obvious, what is its clinical implication or surgical therapeutic implication? Can you answer that first?
Team one. Team one.
See the pictures, right to left.
It might be a extrinsic contracture over the axilla, which is extending from the elbow till the chest and the abdomen, sir.
What is the importance of the scar behavior or the observation when the position of the adjacent joint changes? As you are seeing here. What is the character of the scar you are expecting? What is the loss of tissue you are expecting? Team 2?
Sir, it looks like an extrinsic contracture involving the anterior axillary fold. So when we release the intrinsic contracture, we might there would be sometimes adequate range of motion that can be attained in the shoulder. Then we can decide, do we need to actually do any release of this scar there? It looks that there is an intermediate normal skin in between the two contractures of the chest wall and abdomen, and the scar on the arm to the wrist, which is extending.
That does it mean that one contracture is more severe than the other between
Yes, sir.
axilla and elbow?
Yes, sir. The elbow contracture, which is the intrinsic one, is more severe.
Okay. And if you observe on the left picture, the left shoulder is at a lower level than the right shoulder.
Yes, sir. Yes, sir.
Why it is so?
That is because of the extrinsic contracture, which is trying to pull down.
Start video.
If you have to do Z-plasty at one place and bipedical release on the other, what is the benefit?
Sir, we can do Z-plasty over the anterior abdominal wall and the bipedical flap near the elbow joint.
Anterior abdominal wall or up to the axilla?
I mean, the chest, up to the chest.
And if the contractures are more severe, which doesn't happen like this, as by change of posture, the things are changing bands, then why two major joints are not equally operated simultaneously? Say axilla and elbow, if it is severely contracted, why it is not preferred to operate both of them simultaneously?
Positioning after splintage will be difficult, sir.
You can always splint it. Put 2 splints, one for elbow, one for axilla.
The requirement of graft and the flap which we might need.
You won't have shortage of skin. You know, both the thighs are there.
Team 1.
Chance of recontracture will be more.
Why?
More area has been addressed in the single sitting, sir, and following the splintage and
If your release is adequate, that should not be a problem. You release both of them adequately. That is surgeon's failure. But what is the problem with the patient? Why we don't prefer to, especially in a child, 2 major contractures simultaneously?
Compliance might be an issue, sir, since it's a child. They might not follow through with the adequate splintage and
Splintage following is the parent's job for this child.
as he is growing, sir, there might be change in the contract.
What are the 2 components post-operatively we insist? One is splinting and other is
Physiotherapy.
physiotherapy. Okay. So if 2 major joints are given even to an adult to do physiotherapy, it is painful. So they don't do physiotherapy of either of the joint adequately. Only splinting may be done to some extent. And these 2 has to be continued for 6 months, at least. So there is chance of recurrence. So it's better explain the patient party that we'll do one at a time so that there is no recurrence. They will understand that. And in this, will you do bipedical? What is the advantage of bipedical release?
Can we say?
You know the principle of bipedical release?
Yes, sir.
Yeah.
Sir, in bipedical release, we take 2 parallel incisions outside the.
Where?
Sir,
How do you decide that?
Sir, if there is a scar or the contracture involving the joint crease, we take 2 parallel incisions outside the.
Where? Suppose the elbow is here. You make it here,
yeah,
here. Where you make the incision?
Parallel to the joint crease from the scar and
How do you
normal.
decide the site of the horizontal incision? You have to make one upper and one lower.
One lower, yes, sir.
So how do you decide that? Where to make?
The point of maximum tension.
Maximum tension is across the joint, where the contracture is.
The time is
Carry on.
short.
Okay.
Anyone from judges or senior faculty?
Yeah, one question to the team 1. Yeah, am I audible?
Yes, sir. Yes, sir. Team 1.
Team 1. What is that deformity in the eye that you have said? You said that it is ectropion. Where is the ectropion there? How do you define an ectropion? Question number 2. Whether the deformity belongs to the lower eyelid or the upper eyelid?
The deformity belongs to the lower eyelid, due to which the lateral canthus is also being pulled down because of the scar.
Is it lateral
What
canthus?
happened to the upper eyelid?
Sir?
How can a lower eyelid pull the upper eyelid? It is basically a lateral, can be described as a lateral symblepharon or acquired epicanthus, lateral epicanthus. Okay, acquired. It's not congenital. You understand? And there is a trapdoor effect of the lower eyelid.
Yes, there is epicanthal fold.
Correct. Sir, Venkatratnam garu, would you
This,
like to ask anything?
How can you assess the requirement of lower eyelid skin defect? How much skin defect? Whether you release the epicanthal fold and then reevaluate, or directly go there, or do something else. Team 1.
We can release
Release
and
the,
we can release and see the resultant effects, sir.
Where do you release? How do you release?
Along the
at the point of maximum tension, sir, an incisional release.
How do you know? Why not at the cheek level? Team 2.
Sir, it's like a band which is extending onto the cheek. So
Exactly.
we would like to release it over the cheek, just inferior to the lower eyelid.
Then?
And then assess the defect size, sir.
Yes.
Based on that, we would go for the graft, full thickness skin graft.
That's right. Points to say Team 2.
Any time is left for this quarter or no? I invite Dr. Bhattacharya sir. Over, Srivali? Time is over?
Time is over,
Bhattacharya
ma'am.
sir to...
Yes, ma'am, over.
Over? Okay, then go to
Spotter.
third spotter.
Ma'am, spotters, how long should we display
The panelists are Durga Karki and Dr. Vinita Puri. I invite the
time
panelists.
limit set for this, ma'am?
Time set is 10 minutes for discussion. If no questions are there to answer for the panelists, 5 more minutes will be given. Okay?
Oh,
Yeah.
First
Can you
spotter.
tell me, what all these things are for, where we have used or we are using?
Skin banking, ma'am.
What type of skin banking?
Cadaveric skin banking, ma'am.
Okay. Can you just, see these and let me know what are the uses of all these things and how these works?
Ma'am, after harvesting the grafts from the cadaver, the refrigerator, the first image will be.
Very important is, how you, when you reach the, site, whether it is a house or a hospital, or how you deal with the, relatives or something like you. From the starting, you just tell.
In terms
If there is a call and you reach the site.
Ma'am, just like corneal harvesting, there's a call on the death of a skin donor. We need to reach the site, or if it's a hospital death,
Prior to reaching the site, would you ask any questions? You get a call saying that there is a donor. Is there anything before you, you will directly rush?
Ma'am, we'll ask about the serology status of the patient. We'll ask about any.
Serology status is okay. You will ask. Fine. Then?
Any other?
First important thing.
Anything else?
What are the areas which are, what was the cause of the death? What are the areas available where we can harvest? Because there are limited areas where we can harvest the skin from a cadaver from.
Yes, again, just slow down. You've got a call, right? You've got a call for a cadaveric skin donation. There is a donor in somebody's house, let us say. So the first thing you want to know is cause of death. That is one good answer you have given. What more would you like to know on phone before you proceed?
The age of the patient.
No.
No.
It is very important to see the, how whether you will able to take the graft or not. Something
You are
more
not.
you have to ask.
Whether they have refrigerated the preserved.
You are not supposed to transmit.
Team 2.
The time from the death duration and whether the body was
Team 2
refrigerated.
can.
So you want to know the cause of death, the time since death, and yes.
Whether it is whether they have refrigerated the body or if the patient had any viral infections. So we would like to know the serology status.
Anything else? These are very basic questions first, whether the patient had any skin diseases, what if there was any infection, whether there was any cancer in the patient. Even a cancer patient's relatives may call up and say that they would like to donate, but you would not really go to their house to take the. So there is a big list of negatives which you'd like to clear before you go ahead for the home call or for a hospital call. Asking the patient whether they are serologically negative is okay, but would you do anything to confirm, or would you just go on the basis of an earlier report?
We have to confirm by screening.
That would be by? When you say screening, what will you do?
Do this.
Who is supposed to be answering right now?
Team 1. First 3 are Team 1.
Team 1, no? Yeah, so
Yes,
let
yes.
Team 1 answer. I think this Team 2 answered a few of the queries.
No, which not answered by Team 1 are passed to the
all
Team
right.
2.
So now you have reached, Dr. Durga was asking you the procedures. So you've made your inquiries on phone. Now you have reached the site. Go ahead.
We'll do a spot test, ma'am. Card test for the serology, the viral status. We'll examine the body of the patient.
No, you have to tell what all serological, what all tests. There are few tests which are important.
HSV, we'll check for HIV, hepatitis B, and HSV skin infection. We'll be looking out for.
And
Over
something more. Hepatitis C. Something more. HBS, SCV, HIV, and okay, Team 2.
Ma'am, VDRL.
Yeah, for syphilis. Then after that, Team 1. How you will proceed?
Ma'am, we ask for how long it has been since death. We can harvest skin only within 6 hours of death. So skin can be harvested from, we counsel the patient.
Only 6 hours without preserved, with preservation, with, preserve in the ice, or, there is some criteria.
Without preservation up till 6 hours, ma'am. If the body has been preserved, we can harvest up to 15 hours. Total of 15.
Team 2.
If body was not cool, we have to take within 15 hours, ma'am. If body was refrigerated, we have to take within 24 hours.
I think 6 hours is the right answer for without refrigeration.
Correct.
Right?
6 hours.
Yeah, 6 hours without refrigeration.
Yes.
Also, there are no, maybe difficult for you to understand, there are no set criteria rates done by the center, and each state has their own criteria regarding refrigeration.
Yes.
In how many years? Okay, further to that.
That is correct.
So even if you can just tell stepwise, the first thing is phone call, then you will make inquiries, then you have collected blood for serology. You have taken consent. I guess you have taken consent. Have you reached consent?
Consent and counseling of the patient party, ma'am, because the patient relatives might be concerned regarding disfigurement, or they might have
Whose consent will you take?
It can be a patient's consent before the death.
If he's
a donor. Once you got a call after that.
Is that adequate if you have taken patient's consent prior to death? That is, patient has filed let us say patient has something stuck up on his or her fridge which says that they are a skin donor after their death. Is that adequate? Can you just reach their home and take the skin?
The first degree, relative, the
When
immediate.
you say relative, who can give consent for harvesting of skin for any person?
A spouse can.
So it is always the first next of kin.
Next of kin.
Legally, whoever becomes the owner of the body. It's a very legal thing. It depends on it. Maybe the spouse, it could be the parent or whatever it may be. Okay. It's not just whether they have, even if, let us say that somebody has said that they would like to donate skin prior to their death. If the relative at that time says no, can you yet insist and go to court?
No, ma'am.
No. What are the next points?
The skin is harvested using from areas such as the thighs, the back, and they are adequately dressed. The
You have to do some preparation, which is important here.
We have to paint and drape the donor areas. Harvest.
With what you will paint or clean, there is some standard steps which you have to follow. How you will clean, with which you will clean.
Scrubbing and draping of the donor site.
Team 2.
Chlorhexidine with chlorhexidine, ma'am.
Only? Okay, then proceed. Then after preparation?
We'll harvest sheets from the leg and the lower
What
limb.
are the areas you will, you can take a graft from the cadaver?
Ma'am, the lower limbs, bilateral lower limbs and the back, ma'am.
Only 2 areas?
And chest, back and lower limbs.
Exposed areas.
Back and lower limbs.
Team 2?
Thighs, abdomen,
Lower
back,
limbs, back.
and sometimes upper limbs also can be harvested.
No, not this. Okay, proceed with the team 1. Then after that? With which, I mean, you will take graft with the instrument?
Dermatome, ma'am. Or
Okay, we have to, give you I mean, every time you just keep on telling the steps.
we'll harvest the skin from using a dermatome, and we'll preserve it in the glycerol, ma'am. And then we'll shift
Concentration?
50% glycerol.
Initially in 50% glycerol for transportation.
Then
we'll dress the wound from the donor side of the body, and then after that we'll take the harvested skin in cold storage to the refrigeration for storage, and there it can be stored up till up to 4 months.
Team 2, anything in between this process from harvesting to the skin bank in between? I mean, after that, once you reach the skin bank?
After reaching the skin bank, we have to see for microbiological testing should be done, ma'am, to see for microorganisms like gram-positive, gram-negative, beta hemolytic, streptococci, antifungal and antiviral. If it is positive, we have to do it again, and if it is again positive, we have to discard it, ma'am. After that, we have to see for viability. We have to see, ma'am, by keeping it in 20% glycerol. We have to keep for 4 hours.
How much glycerol?
20%.
Team 1?
10%.
10%.
Okay, team 1, now proceed with the, these what are shown in the figure. And, can you enumerate what are these things, how we use these machines in the screen?
The refrigerator will be used to store the graphs initially. The biosafety cabinet is for sterilization of the harvested skin. Then
is it for sterilization of the harvested skin or something else? Do you do any procedure in the biosafety cabinet, or you just put something inside the biosafety cabinet?
So just you put a graft and you just close this
Machine.
machine.
We can
We
do.
are in the last 5 minutes, is what I understand.
Team
Dr.
2,
Lakshmi.
team 2. What is the use of biosafety cabinet?
So you actually process the skin in the biosafety cabinet. Okay, both the teams. This is what you should understand.
Okay.
Right. Once the processing has to be done, it is processed inside that biosafety cabinet with all sterile techniques. Right.
And you have
So
to
I want to
protect
ask you a question beyond this, because we are going beyond time. I think we have only last 5 minutes left. What, other than glycerol preservation, what are the other methods of preserving skin that you know of?
Preservation.
Solid carb, liquid.
Other than glycerol preservation,
Liquid
what are
nitrogen.
the other methods of storage of skin in a skin bank?
Liquid nitrogen, ma'am.
some name is there,
Cryopreservation.
Cryopreservation. Do you know of any other method?
And what is the temperature in liquid nitrogen?
Liquid
Minus-
nitrogen.
Minus 196 degrees Celsius.
Okay. Okay, tell other method, ma'am is asking.
Is there any other method?
Dry ice, solid carbon dioxide, dry ice.
Dry ice, I'm not very sure. There's another method. We have a skin bank in India who is doing that.
Lyophilization.
Gamma irradiation.
Wow.
Which is known as
Tata-
gamma graft. They are called as gamma graft.
Gamma irradiation. Tata Tissue Bank is actually doing that for a very long time. I want to know that you all mentioned only skin banking. What are the other banking that you have all these, all this equipment that is there. What are the other tissues that can also be stored? When you say you have a tissue bank, right now you're talking only about skin banking. What are the other tissues that can be harvested and stored in a tissue bank?
Team 1.
Ma'am, chorion, amniotic membranes we can store for then cornea.
What do you store in it? Do you store the chorion?
What
Amniotic
other
membrane.
tissues?
You said skin and then amnion. What else?
Corneas can be stored, ma'am.
What else?
Generally, corneal bank alag hi hota hai, eye bank. We are not really, when we say tissue bank,
Yes.
because eye banks are very common and they are not really being mixed with the tissue bank. Anything else?
Temperature. Okay.
So right
Team
now we have
2.
only skin and amnion from you. Do you have any more answers? What other body tissues can be stored in a tissue bank? Processed and stored. Either of the
Cartilage.
teams can answer since
Cartilage.
cartilage. What else? So fascia, tendon, nerves, veins, heart valves, and most importantly, bone. Right? Have you heard of bone, allograft bone? Have you heard of that? Yes or no? I hope you have. If you haven't, please go up and read about bone. Let us say that somebody wants to harvest a femur from a cadaver. Do you have an idea how that is done? Or I should say, can you just harvest a femur and then how do you hand over to the relatives? For the skin, you said that we can just put on a dressing. If you have harvested the femur from a cadaver, somebody says, yes, take all the tissues that you can and you have harvested the femur. How are you going to reconstruct? Will you give an unstable leg to the relative's back? You won't. So you'll reconstruct. Can you tell me how you will reconstruct? Any of the teams?
We can just put rods and screws or an external
So it's
extremity.
not rods and screws. Usually just a wooden rod can be put. Because finally the body is just going to go in for the last rites. So you don't really want metal in there. You can, if you're going to go in for a bone harvesting, then you have to be ready with these things. Now last question, one, because it is on skin banking. Where are you going to use your cadaveric graft? Please be very specific, point-wise.
Tell indications.
Conditions.
Large area of burns requiring cover for during initial period, ma'am.
So instead of collagen, you'll use that? Is that what you're saying?
When will you use?
In deep burns, ma'am, when we require coverage, we can use the that as an allograft for coverage.
So you have deep burns,
Directly?
just apply it.
Team
Ma'am?
2, shall we go?
We
Because
can,
It's very simple answers. 1, 2,
We
3,
can use as a
5.
temporary dressing, and when the wound bed is not ready, to prepare the wound bed. And in patients in whom the donor areas are insufficient,
This is one indication. Others?
as a part of the sandwich technique in
Very
grafting.
good. Very good. So it's part of, so wherever you have very widely meshed autograft, you can apply it on top. What else?
And as a temporary dressing, especially in, I mean, like in pediatric patients, before going for autografting, to prepare the wound bed as a temporary dressing, we can use.
Would you like to use it after excision of the burn?
early excision.
When an early excision, would you like to use it, or you are going to just do it directly, apply the cadaveric
No.
graft on?
After excision, if
Can
the
you
donor
apply?
areas are not sufficient.
Yeah, so even if the
Yes.
donor areas are sufficient, let us say you have a 35% burn and you have done an excision of 20%. Is there
Yes,
any
ma'am.
reason why I would say that let us go ahead and do a cadaveric graft? So you actually tell in this, I'm giving you the answer because we are also in the answer phase.
Because there would be
Testing the
blood loss.
application of the depth.
Yeah, yeah.
Because
What
there
is
would
the
be
application of the
condition.
depth of your excision? Right? You have excised, you're not very sure whether the depth is right. So if your allograft takes, then you're sure that your autograft will take later. Toxic epidermal necrolysis. That's another place where you may or may not,
Correct.
you can even use amnion in those cases. Right? That tissue from the tissue bank. Wherever there is severe trauma, you've got, let us say, a lot of avulsion of skin in the whole lower limb, bilateral lower limb, you're not going to be able to autograft immediately. You can put allograft skin. So there are many uses of skin from the bank, and it is not just from the for burns.
I thank you. I invite moderator to put some questions or
Yeah,
summarize.
I have two technical questions. One is that when you harvest the skin from a cadaver after few hours, whether you are taking by an Humbee's knife or a dermatome, is there any difference in the width of the graft? Suppose the Humbee's knife in a patient, when we use it, we can use full width of the Humbee's knife blade graft if the position is well given by the assistant. Is there any difference in the harvestation of cadaveric skin and live skin as far as width is concerned?
In cadaveric skin, we can take 3 to 4 inches of width, sir.
Why not more than that? As I said, we can take full blade graft by a Humbee's knife.
To get the consistent thickness of the graft and uniform sheets.
I'm talking only of width.
It's only 3 to 4.
Because if you can take large width of graft, then it is very quick. Okay. But the point is that you cannot take. Why? That's what I'm asking. And the second point which I wanted to ask is that when we preserve the skin and say amniotic membrane, as madam was asking, the duration of safe limit of using these are same or different? Suppose today you place the amniotic membrane as well as skin, the duration of utilization will be same? It can go to any team, team 2 also. Which one will be more stable? Let me put it in that way. Both can be used as a homograft.
Amnion is more stable. So skin we need to use within 10 days.
Team 2? Okay, no problem. See, the first question is that in cadaveric skin, the rigor mortis occurs and the skin to some extent also wrinkles. And even if your assistant is trying to give a good flat surface and a tense surface, he won't be able to give, because the skin has become hardened. It is possible only in live people. Okay. So the width of the skin graft will be automatically reduced, howsoever good you try. And the skin is more stable than the amniotic membrane. So amniotic membrane has to be used earlier when you store it. Thank you. Dr. Lakshmi?
Yes, sir. Anyone other than other panelists or the judges would like to ask?
Can I have the
Yes, sir.
bank for picture back?
Srivalli?
Slide.
Yes, ma'am.
Please go to that
Skin bank.
Skin bank slide.
I think the second one, the spelling, is it correct?
Sorry, sir, that I could not correct it, but panelist already spelled that biosafety cabinet.
I know, I understand. Because I have not seen live. That's why I thought whether it is
no,
comes from the company or
biosafety
you
cabinet. A panelist already corrected it, sir. I could not do it. Sorry.
No, I only wanted to know from whether it is coming like that from the
very
company.
keen eye on these, always on these things.
I am blamed for that.
Always
I enjoy
found
it. Okay, over. Thank you.
The all processing of the skin bank will be done in this biosafety cabinet only. We'll move to the team 2. The 3 spotters completed by the team 1. So, Dr. Harika and Dr. Radha Manjusha from Gandhi Medical College, Secunderabad will participate. The first spotter for them. Dr. Uma and Anjana will lead the discussion. Even
From
the
the
spellist
pictures,
of the Umar is there.
from the pictures, what is your diagnosis? What are you seeing on the screen?
Team 2.
These are the extensive thermal burns, sir, involving both upper limbs and right lower limb and abdomen, face and back.
Pairing the groin.
And?
Go ahead. Can estimate.
Go ahead. You go on speaking.
You received this patient. How you go away? You go on steps.
How can you go ahead with this patient?
Sir,
you
first,
received this patient,
what will you
small
do?
boy in the casualty emergency. How will you proceed?
First, we would stabilize the patient, check for the airway, breathing, and circulation. We would put broad IV cannulas and start resuscitating the child first. And we would clean all the areas of the wounds and assess the percentage and degree of burns. And since the facial burns are also seen, we would give him oxygen supplementation. We would check for the saturation levels of the child, and we would simultaneously we would get the history from the parents or the attenders available. What is the cause of the burn?
What do you think is the
What is the percentage? You calculate the percentage. You are seeing the front and back, and it's 11-year-old child. So
Right lower limb, posterior aspect also involved. Left lower limb, but no burns. Okay, except that small patch.
What is the percentage now?
What is the percentage now? Unmute.
54%. Around 55,
Approximately
60%.
How did you calculate?
based on the London Browder chart, since it is a 11-year-old child.
How much have you taken the face and neck to be percentage?
Ma'am, approximately 12 to 13%, and the chest 13%. Each limbs anterior, upper limbs anterior 5 and posterior 5, and the lower limbs 10%, anterior and posterior.
The left upper limb, the back is spared. If you see the second picture from the left.
Yes, yes.
Yes, ma'am. One upper limb back is paired.
Okay, so in other words, could you just tell us how the percentage calculation changes from a child of 1 year to the child, till he becomes adult? What is the percentage? I mean, by rule of thumb, what do you have to calculate?
The head circumference in the child is more compared to the chest and the trunk, which keeps on decreasing with the age of the child. So in a child of...
It is 3 times more that of the body mass ratio when compared to adults. Head.
That is for your fluid resuscitation and loss. I'm talking of the percentage. In a 1-year-old child, how much will you calculate the face and neck? And then from there it goes decreasing.
Number.
Number you were to tell.
1 year, it is approximately 20%, ma'am. Coming to 3 years, it would be 15, and then it would decrease to 13. And by the time it is adult, head and neck comprises of 9%.
Okay. So seeing
the trunk,
apart from seeing the percentage, what else will you see?
Depth of the burns.
Degree.
So seeing the picture, what do you think this burns is?
Ma'am, the image looks moist pink color. So yeah, I think it is superficial partial thickness thermal burns.
How old is the burns, do you think, seeing the picture?
How many days have passed?
Could be 1 to
2 days.
2 days.
Yes.
Team 2?
Team 2 is the answering, madam.
Team 1, sorry.
Team 1.
Looks like, sir, 4 to 5 days have passed, sir.
How can you say that?
Sir, we can
How
see.
did you get the clue?
Sir, there is difference in the color, sir. Deep areas are also starting to become visible in the
Where is
arm.
the deep area?
Sir, like the right side, the rightmost photo, sir, of the upper limb over the wrist region, sir. It looks paler compared to the pink region, sir.
I think we
What
can
are the other
proceed.
ways of
It is
calculating the burn percentage?
Sir?
Sir?
What are the other ways of calculating burn percentage?
Sir, rule of palm. The patient's palm is equal to 1% of the total body surface area. So, and
rule of 5.
Rule of 5, which is used in pediatrics, and Wallace rule of 9, which is used in adults, and the London Browder chart.
Okay, so you have calculated you have seen the depth, you have seen the percentage. So now what will you do?
Ma'am, since large areas are, large percentage of body surface is involved, we would continue with the resuscitation, stabilize the patient, and we would start dressing the wounds and giving adequate...
Stop. How will you resuscitate?
Sir, in our institute, we follow the Parkland formula, which is 4 ml per kg per percentage of total body surface area burnt in the first 24 hours. Of this, half of the volume is given in the 8 hours, and the next half is given over the 16 hours. And from the second day,
8
we
hours
start
from admission.
children
Is it
also?
8 hours from when? From admission?
from the time
From
of
the time
burn
of
injury, ma'am.
In
Okay.
children also you follow the same? Or you add
Sir,
something, you
here
subtract
the
something?
child is since 11 years old. We can go ahead with the adult formula of 4. But otherwise, if it is
3
a pediatric, we would go for 3 ml.
11
Your
Sir?
voice is breaking. Uma,
You can't be heard, Dr. Umar.
Dr. Uma, the audio is not. Anjana,
Yeah,
please
I'll
continue.
continue. So
Yeah.
you are using Parkland's formula. So how will you monitor the adequacy of your resuscitation?
We have to check for urine output monitoring, ma'am. In pediatrics, it should be at least 0.5 to 1 ml per kg body weight
Per
hour.
Yes, per hour. So is there any other, and what investigations will you send after the moment you're putting in a channel, you will send the blood for some tests. So what will you send it for?
We would send for CBP, electrolytes, renal parameters, urea, creatinine, liver function tests, serology, and ABG, and
But-
electrolyte levels.
Yes, but amongst this, what is the main thing you will monitor for your adequacy of resuscitation?
Creatinine level.
Team 1?
Ma'am, the creat level, ma'am. The urea
Oh.
creat.
In the early first 24 hours, apart from urine output, what else shows you the adequacy of your fluid resuscitation?
The color of the urine.
Hematocrit
Hematocrit values.
The hematocrit
Yes.
value.
So that is the answer we are looking for. Dr. Umar, you can continue.
Are there any special formulas for children for resuscitation you know of?
See. Modified Brooks is.
Modified Brooks formula, sir.
Anything else?
Team 1, they
Yeah.
can answer.
The Galveston formula or the Schreiner-Cincinnati formula, especially
Yes.
used for
What
children.
are those? Can you elaborate or?
In Schreiner-Cincinnati, ringer lactate is used 4 ml per kg body weight plus 1500 ml as maintenance dose.
1500 ml per?
Per meter square.
Per meter square. Good. Yes. It is ringer lactate, right?
Yes, ringer lactate.
And in the Galveston?
5000 ml plus 2000 ml of ringer lactate in over a
Per
period of
meter
24 hours.
Good.
So in pediatrics, what are the special things apart? I mean, how do they differ from adult burns?
It is always said that children are not small adults. They are the children, right? The
More
old
of
adage.
As the area is more
more evaporative chances, and then
What is more? What is more?
head circumference is more, sir.
In a right sense, what is more?
That head circumference you have already taken care of in your percentage calculation. But what actually happens in children? There are 2 or 3 things which are very important.
Unique in children.
in children, there will be depth of burns will be more, ma'am, because the dermal layer will be involvement will be more when compared to adults, and evaporative loss.
The dermis is thin compared in children and in elderly. The skin is thinner, correct then? One is that, second?
Point.
Evaporative loss
Team
will
1,
be more in children.
team 1.
Sir, first is that in pediatric patients, the body surface area is more, so evaporative losses are more than
Body
the
surface area compared to
adults,
compared to
and
weight.
compared to the weight.
So
weight. Body
Weight,
surface
it's
area as
not
per the weight
compared
is
to
more.
adults. Yes.
Weight, sir,
weight.
weight.
Then
So evaporative wall losses are more, and sir, the thickness of the dermis is around 70% of the adult, sir. So it is
that
more
is done. That is done. That is
than
already
That they have already told.
Anything, third point.
so
Third
basal.
point.
So the basal blood pressure in pediatric age group is comparatively less, sir. And the renal function also, kidneys are not fully developed, sir, till the like in
Infants.
infants, sir. So the urine
And
output will not be an adequate indicator.
and
Glycogen stores are not adequate in children, so supplementation from outside is required. So D5 glucose is also has to be supplemented along with the fluid
good answer.
Correct,
Correct.
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 So you have to take care of hypoglycemia, which is very, very common in the pediatric population. But
Actually,
what?
if you go to pediatric population, one point I want to add, you are following the parkland. And when in pediatric you follow the parkland, you give the maintenance to the children, right?
Yes, sir.
Yes, sir.
Or
We
you
add a
follow the
maintenance.
whatever the standard formulas, or you add the maintenance fluid. And if they are very small, then you add the dextrose also because glycogen stores are less.
Yes, we add maintenance.
What
Then how
kind of
will you
nutrition? It is now day 3. When will you initiate nutrition in these patients? And which route?
Enteral route is always preferred if the patient can tolerate, ma'am. It is better we start with at least liquids from the post-burn day 1 by initiating liquids like clear liquids first by making the patient in sitting position. If the patient is tolerating, then we can move to thicker liquids and then to semi-solids by day 4 and day 5. And by day 5, if the patient is tolerating, it would be, we should go for a high protein diet.
If the patient cannot tolerate orally,
then we can give the feeds by a Ryle's tube.
Yes, so where do you place the Ryle's tube here in children?
If nasogastric route is difficult, we can go for an orogastric insertion also.
Yeah, but even in nasogastric, what is special for children?
Nasojejunal.
Team 2, team 1?
Nasojejunal.
Yes, the
For
nasojejunal.
better
It's easier to put because the pyloric sphincter is not that
Sphincter.
well developed, so it goes straight to the jejunum and you can give feeds which will be better tolerated. In children, what is another thing you have to be very careful of or take special care about? You are now cleaning the patient, you're doing the dressing. So what you have to be very careful about?
Positioning and splinting the child.
That is like all burns you have to do that, but for pediatric
anything
population, you have
special
to
in
do.
children?
Team 1?
The hypothermia, and because at less than 6 months of age, the baby will not be shivering. So that time we have to look for hypothermia and be vigilant about it. Bed walks will be there.
Yeah, hypothermia is one. And what is the other thing we are
Next,
actually
go to the
looking for?
next now. Hypothermia is one.
The second thing.
Pain, adequate analgesia.
Adequate analgesia is very important in the pediatric population because if the first dressing they get pain, they are never going to allow you to touch them easily in the next
How will
few
you
days.
dress the wound now?
Time for panelists is over. So
Okay.
I invite Dr. Bhattacharya sir to put the questions, ask the questions.
Looking at the picture of the patient, what do you think is a thermal burn or a scald burn?
Maybe scald burn, sir.
Why?
Superficial.
So diagnosis is already there, sir.
Why? Okay, let it be scald. Why? If the diagnosis is not there, why it is scald burn?
It is
No,
written
sir,
there.
it is a flash burn actually.
It is written there.
What you look at the back, what the back is free. What is its importance?
Sir,
How the back is free? What is the explanation?
he was exposed. If we are saying it's a scald burns, we can think that
Hot water.
he fell in a hot water or some liquid fell on him from the anterior side, which is, I mean, he tipped off a bucket of hot water or something like that.
If this splash word was not incorporated in the diagnosis, I would have thought of scald burn. Somebody has thrown or any accident has occurred from the front, what usually occurs, and therefore the back is spared.
Yes, sir.
That's the explanation. Second thing is, does the calculation of fluid depends upon the depth of burn? You said it is second degree.
Yes, sir.
So if it is second degree or if it is third degree, your calculation of fluid will differ or remain the same?
Sir,
Same, sir.
Sure?
the fluid requirement will actually increase if it is a full thickness burn, sir.
I think panelists will throw some light on it. And the other thing is that what is the role of splinting at this stage?
To prevent
For upper
any
limbs?
contractures to prevent the contracture formation, sir, since neck is involved and upper limbs are extensively involved.
To decrease the edema over the dorsum of the hand, splintage is important, sir.
How do you prevent the second degree burn, as you said, to move into the deep second degree or third degree?
First thing is adequate resuscitation, sir.
Resuscitation is to resuscitate the patient is vitals. I'm talking of the depth of burn. How will you prevent? What precaution will you take from the beginning? You'll keep in mind that this should not become deep.
Regular
or daily
dressings
dressings.
to prevent any infections and early excision.
Any latest thing which you apply in dressing, which might
Wet collagen dressings we can do, sir.
yes. How costly it is for this patient?
So since a large percentage is involved, it would be costly.
So instead of that, can you use something else to prevent?
Homograft application can be.
That is
Amniotic membrane.
Everywhere it is homograft is not available.
Amniotic membrane we can source from the gynec department and we can use amniotic membrane also, sir.
Again, it is not that easy as it is said. How many times you have used amniotic membrane? Have you? No. So the last question is that if you have to educate a local doctor at the periphery for this type of burn, what will you tell him?
So we would tell him to immediately start resuscitating and shift the patient to a burn center.
What else? That is the easiest way. Refer to another hospital that everybody does to save themselves more than the patient. So how will you educate the peripheral doctor?
Immediate cleaning and dressing of the wounds.
I'm not talking of this patient. Through this patient, if this type of patient comes to him or her, what should be done? How will you educate?
So we would tell him the guidelines regarding the resuscitation and management of burns in children and what are the criteria for him to admit the patients, in-house management and the burns which can be managed at home, and what are the criteria when he has to shift the patient to a burn center for further management. and also tell him regarding the preventive measures which he can tell in his area, like if we are thinking it as a scald burns, like you said, I mean, to educate the parents how to prevent them at home.
See, then all the complications would not have happened if he knows that much of thing. The main thing is that you have to tell him that how to take care of immediate take care, and how during that taking care, how he should prepare to transfer the patient to a better hospital or a higher hospital. But he should not lose the primary time from time of burn to the transport to a hospital, because that is so crucial. Because the fluid resuscitation also depends upon that. It is calculated from the time of burn, not from the time of hospitalization, isn't it?
Yes.
So that is very important part. And of course, the local dressing. Thank you.
Thank you.
Any questions from judges or Dr. Venkatratnam?
Yeah. If the patient comes to you immediately within a few minutes, within the first hour, what will you do? Such an extensive burn, what will you do? While taking the history and then documenting, giving the IV, do you do something else? Sort of first aid, but it can be prolonged also. And what precaution you will take while doing that? Another team?
If it is circumferential flash burns annar kade.
This is team 2, right?
Yeah, team 2.
Yeah, I'll supplement the question if you allow me. The thing is that one thing you are observing, as Sir had said, and another thing is what you are doing at the same time. Suppose you
Yes.
are observing the burns, you are assessing the burns, your teammate or your nurse or your technician is doing something. You are assessing the kind of circulatory thing, the blood pressures and all, and somebody else is doing something for that. You are assessing the happening of the respiratory burns, and somebody else is doing at the same time. So time is not wasted. So these three things which you see in a patient, once you examine it immediately, somebody else in your team is doing something for that. So let us know, once you are observing the patient, right, it moves into the emergency. Suppose you are taking about the blood pressures and all, what is your teammate doing? And you are assessing the TBSA, what your teammate is doing at the same time, not wasting your time.
One person would be taking the history from the patient and the attenders, while the other would be assessing the wounds and start taking the vitals and securing the airway and resuscitation.
Yeah, what is the kind of approach, the resuscitation and all? Malab, would you like to start the IV drip immediately? Your colleague would start to put in 2 lines, 3 lines, or 1 line, depending upon the TBSA. And also, would you like to give oxygen first, with our right way assessing the inhalation burns, and somebody would put the oxygen on mask so that you don't waste that half an hour assessing the thing and oxygen saturation falls. So somebody is putting in the pulse oximeter, or if you are capable of putting a central line, the other person is at that moment doing something. So that is how the approach goes. I'm right, Dr. Venkat?
Yeah, I'm not sure whether you have come to the point. You may be thinking.
You can,
One,
yes,
let
go
me
ahead.
see. Let me see. I'm
Go
waiting.
ahead.
I'm waiting.
Yes.
I think Dr. Venkat is saying something which is the slogan everywhere. I think
Yes.
Dr. Venkat,
Yeah,
mean
yeah,
that.
I think I got it. Yes.
Burns and water.
Huh? Team 1.
Sir?
Team 1. The patient came within a few minutes with this extensive burns. You are doing all the routine protocol, but at the same time, what will you do? Another important thing.
I'm giving a hint, it can be done up to 2 hours.
Exactly, yes.
First aid. What is the first aid?
We need to stop
It can be prolonged also a little bit more.
Pouring something on the
That is
Cleaning
first
the
aid for
wound is
burns.
Running water for 20 minutes.
Cleaning the wounds.
Cleaning the wound and
stopping the ongoing process if it is there and removing the clothes.
Okay. Both are not in time. I will add it. That is hydrotherapy. Did you hear about hydrotherapy?
Yes,
Pour
sir.
water. Pour water.
Yes,
That
sir.
is
Pour water on burns. That's the
Pour
slogan
water.
put everywhere, no? So,
how does it help? What is the mechanism? Why they say pour water?
So first, it will cool down the raised temperature, so it would halt the ongoing process, and it gives a soothing effect to the patient.
And depth of burns will be decreased, sir.
How?
Sir, since
Okay.
the ongoing thermal injury is halted because of the rise in change in the temperature when we pour water.
Technical, in the depth, what happens? That means immediately the tissue retains the heat. That heat will be transmitted if we leave it alone, and the microcirculation will be, thrombosed. That's how it keeps on increasing the depth of the wound. So superficial second degree can become deep second degree or like that. So to prevent that, simultaneously, within the first 1 hour, 2 hours, if the patient comes, we have to wash away the heat continuously. And it is not painful. But I also asked what precaution you will take. Patient should not go into hypothermia.
Hypothermia. We should use
especially in
normal.
pediatric population, that's a
Yes. Yes.
We should not be
So
using
these
cold.
are the two things. There is one more question from my side.
Sir, time is over, sir. We have
Just
to
one
go
question.
to the. Okay.
Just one question. Okay. This one question is how will you prevent? You have admitted the patient. How will you prevent infection? It's a huge area, body surface area. During the nursing or during the dressing changes or in between.
Hand washing between before touching the patient and after.
Okay. Since Dr. Lakshmi is bullying, I'll tell you that is. Did you hear about barrier nursing?
Yes, sir.
Yeah. Okay. So it's over from my side, Dr. Lakshmi. Thank you.
Thank you, sir. We'll move to the second spotter. We are running more than the time. Yeah.
Yeah.
Dr. Vinita and Dr. Durga are panelists.
Okay, so what do you call this position? Okay.
Team 2.
It is intrinsic minus position, ma'am. There is hyperextension of the MCP joint and flexion at the PIP joint.
Okay. And what about
And thumb is adducted, ma'am.
Adducted. Okay. Now, what is the reason for this deformities in bones?
Initially, when the burns happen and when we are not giving
Adequate dressings,
adequate
splintage.
and position, there can be dorsal edema on the dorsum of the hand, which will progressively take the MCP joints into hyperextension, causing shortening of the collateral ligaments and causing the PIP joints to go into flexion.
So edema. One point is edema. What else?
Yes.
So you said edema, you said inadequate, or you should said, you basically said no, basically unphysiological positioning, right?
Yes.
No
ma'am.
splintage.
What
If it is
else?
not
Edema.
And since the skin on the dorsum is thin, more chances of contract dorsum.
So direct thermal damage may happen or no, or is it only direct? Is it only edema?
for team 2.
No, ma'am.
No, sir.
Direct thermal damage can happen more
I'm
because
asking you, what are all the reasons that you will get an intrinsic minus position or any hand deformity?
direct thermal injury, edema, and Position.
Either lack of positioning or wrong positioning. Then next.
Wrist inflection.
Can the other team answer?
Team one.
Direct.
Already don't repeat what has already been told. Any other points?
To the extent damage to the ongoing scarring will have involvement to the extensor tendons.
The attenuation of the extensor tendons or injury, that is already direct thermal damage. What else? So I'll give you the answer right now. There may be vascular insufficiency. Maybe you do a wound closure late, or you don't do a wound closure. You are allowing secondary allowing it to heal secondly. There may be wound infection. There are many reasons which can lead to a hand deformity. Right? So it is not just edema.
Can you tell the diagnosis of this patient? Team 2.
Postbun sequelae involving bilateral upper limbs with the hands in intrinsic minus position.
Diagnosis. Team 1.
Post-burn contracture of bilateral hands. With
anything more?
With the bottonia deformity over the all fingers.
Anything, any classification of this hand contracture?
Team 2.
Yes, ma'am.
Team 2.
Ma'am, Macaulay classification.
There are 4 grades, ma'am. In grade 1, there is stiffness of the hand.
What is the classification here in this patient?
Grade 4, ma'am.
4 has subdivision also?
Yes, ma'am. First, 4 has flexion.
What is the subdivision here? Just tell the diagnosis of this patient.
4C, ma'am.
It's a post-burn contracture.
Macaulay grade.
Post-burn contracture hand with the claw deformity and Macaulay class 4C.
Yes, ma'am.
And in the history, what are the 4 points which are important in this case? Only 3-4 salient points which you will take.
Ma'am, the cause of injury, the course of treatment, whether it was operated or did it heal by its own, or whether any grafting was done, and whether if any procedure was done, did the patient follow any physiotherapy or splint test protocol post the procedure.
In the examination, what all you will tell in this patient? What are the positive points? In the examination, you take one hand, right hand.
Yes, ma'am.
Just tell the positive points.
Ma'am, we see a
MCP hyperextension, ma'am. And there is hypopigmented patch over the dorsum of the hand and fingers. And IP joint flexion, ma'am.
Your time is, going. Just tell all the points in the examination.
Everything that you will examine. You cannot examine this patient right now, but at least you should be able to tell what you want to examine.
Ma'am, we would examine the active and passive range of movement of all the joints, starting from wrist, NCP joints, PIP and DIP.
Okay.
Would see the range, and the condition
most
of
important is to start with the attitude, which you told earlier, but the attitude of the hand is important. Then you go directly to the joints or something else.
No, ma'am. First inspection. So we look at
hypopigmented is okay. Then other. You have the palmar area also, and lateral view also. All views are there.
Ma'am, in the
hypertrophic scar is noted, ma'am.
In the palmar view.
Team 1. Can you summarize the examination within 5, 6, 7 important points?
starting from first, ma'am, inspection. First is the attitude of the limb, then any pigmentation changes.
That is done. Okay.
Then palpation में any loss of sensation, any passive and active movements we'll be assessing.
Pliability of the joint, whether the joints are supple.
Anything more?
Loss of the metacarpal arches, reversal of the metacarpal arches.
Which
Ma'am?
arches? Which arches?
Distal transverse metacarpal arch.
Okay. Anything more? You have to just go through the examination. Now the treatment is also there, you know, time is very short. Any positive finding which are important for the reconstruction? You have to see the web spaces. First web is contracture. Whether there is any contracture in the rest of the web spaces which are very important. Then you have to see the, you know, grips. What all grips are there which are very important. Functional examination of hand. Grips are important. What all grips are there? You can, I mean, you can see what are absent or, you know, compromised.
Grasp, pincer, grasp and key pinch.
Precision pinch.
Yeah, these are important. Then any other examination? Team 1.
Skin, joints, sensations.
Then
Donor
important
area.
is the pulse exam. Pulses are also very important. Pulse examination, which is important.
So when you do a burnt hand, when you're examining a burnt hand, remember that the examination pattern remains the same, whether it is trauma. You have to talk about the vascularity, the neurological status, the active and passive joint range of motion. All that needs to be essentially done. Just because it's burned, don't think that you don't have to talk about the vascularity or examine the vascularity.
Yes, ma'am.
Now, how would you like to manage this patient?
Ma'am, we would release the scar over the dorsum of the hand.
Don't start with release. There are two hands which are involved. Are you going to operate both hands simultaneously?
No, ma'am. Ma'am,
So
we would.
first question is, which hand will you operate first?
Ma'am, since it is functionally more important, we would go for the right hand first.
You do something preoperatively for some investigation before going for the release?
Yes, ma'am. X-rays of the hand.
What you will find
to
in
look,
that?
To look for the joints, if there is any subluxation or
What do
any
you think in this case?
could be of the MCP joints, ma'am.
What MCP joint? What abnormality?
Subluxation.
Maybe you are not, I mean, range you cannot assess with the photograph, but still, you know, what abnormality will be there in the MP joint?
Subluxation could be.
What is the difference between the dislocation and subluxation?
In subluxation, there is the articular surfaces.
Speak one by one, you know, very difficult to.
In subluxation, there is some contact of the articular surfaces which is still being maintained, whereas in dislocation, there is no contact between the articular surfaces and the joint is dislocated.
Okay, any other thing you will see in, other than dislocation or subluxation? Team 1.
And the angulation.
The interphalangeal joint position and angulation, whether the joint.
Any arthrodesis or, you know, joint fusion or some erosions or, you know, some arthritis, which are important. Okay, then proceed with as ma'am was asking regarding the management.
So the first question will be, you decided that you want to do the right hand. Do you think it is important to ask the patient which hand they would like done?
Yes, ma'am. Definitely after asking the patient. Ma'am, just like the reason I give, the patient might have their own preference or their own functionality. If the patient is left hand dominated.
Yeah. So despite both the hands looking similar on a photograph, it is possible that one may be able to do something a little better than the other. It is very important to ask the patient what are their thoughts. and which they would like done first. In case one hand between two hands which have a contracture, if one contracture is less severe than the other, which will you choose to do first?
The severe contracture.
This can have a very long answer. I am saying both the hands are involved. One is less severe than the other. Now, looking at all factors, which will you operate first?
Ma'am, if the dominant hand has a more severe contracture, and if it is more important for the patient, I would go for the dominant hand with the with the severe contracture release first, followed by the other.
And what if whether both are? I think I'll give the answer directly. If you have both hands which are involved, and one is less severe than the other, even if it's less severe, you have to basically know whether any one of the hands are working and functional. Okay, so if there is one hand which is more functional and is actually able to function, you can always operate the other hand so that they at least have one functional hand to be able to manage their life in the meantime. So it's a balance that one has to maintain. If both are non-functional, then you would prefer to do the lesser one maybe first so that you can bring that into function earlier. So that kind, or maybe do both simultaneously, but usually however bad the hand is, in some way they are able to, with some adaptive devices, use the hand. So you have to always find out in detail what is the function, and after that only decide between both hands. Now let us say in this, just pick any one hand and say what you would like to do.
Right hand, release the flap.
So let us say you're operating the right hand. What would you like to offer this patient?
First, we have to release contracture over the MCP joint, ma'am. By doing
Then you tell
capsulotomy.
the procedure which you will do. What procedure you will do?
Capsulotomy will be doing over the MCP joint, ma'am. That is.
You start with the capsulot.
We would go for an incisional release of. We would go for an incisional release of the contracture and capsulotomy of the MCP joints. And
where you will give the incision? Where you will give the incision? Over the MP joint?
2 centimeters proximal to it, ma'am.
Proximal to the MCP
No,
joint.
2 centimeters proximal to the MCP joint.
Why do you take the position proximal?
Ma'am, so that after release, the graft is on the dorsum and it does not come over the joint, and we
What do
don't
you
create
think in this case, joint will be spared or covered with any flap which is there, skin is there? What do you think? Adequate amount of skin on the dorsum of the hand is there so that it can cover the MCP joint?
Ma'am, here in the photographs, it looks like the complete skin is involved over the dorsum and over the fingers also. So a flap would be a better option in this case after the release of the contracture.
All she's asking is that even if you go 2 centimeters below the expected MCP joint, it is possible that after you're doing a release, that distal skin will slide beyond the MCP joint and it will go onto the fingers. I think that is what Dr. Durga is.
Yeah, because the proximal phalanx is almost,
there's
that
barely
almost
any
touching.
Yes.
Yeah. So other than the MCP contracture and the MCP extension and the IP inflection and the thumb, what else is there? Probably there'll also be syndactylization of the fingers. I don't
or
know
some
what
web
to make up. Yeah, there will be some web creams.
And web contracture is also there.
Time is
So
over.
Tell the complete procedure now.
Ma'am, we would go for a incisional release of the scar with the flap covered.
No, what all to be released? First web is also there. You will leave the first web for the second stage. You will only release the finger at this point of time.
No, ma'am. First web always takes the priority. First web and over the dorsum of the hand.
And what graft or flap covered with?
Ma'am, I would like to go for a flap cover in this case.
Tell the name of the flap.
Groin flap.
Any other thing you have to do in this case?
Ma'am, we might have to put a K-wire into the fingers after keeping them in position in
Where
extension.
to put the
Position, what
K-wire?
position?
With flexion at MCPs and extension at the IP joints.
So are
Where
you
you will
going to
put
do
the
a flexion
K-wire?
release? Are you going to do the IP joint release simultaneously?
Say yes or no, team one.
Yes, ma'am. Yes, ma'am. Yes.
You will do it
Okay, you will do the PIP, DIP, everything release in the single cycle.
simultaneously.
Where you will give the incision
no.
for the PIP? Team one.
Team 1.
Your, what procedure you will do? Just tell in the short 2 lines.
Ma'am, we can proceed because it's
Then
a
what you will do?
distraction. We can try
Where?
distraction histogenesis.
Where?
Action for the fingers, because there might be.
You do
See,
you
the
tell the complete procedure.
question is, will you simultaneously release the IP joint or not?
No.
No, ma'am.
Because it is competition.
Why not?
Because there
why
might be
yes?
shortening of the design.
I am not willing to accept no as an answer. I think it should be released because if you're going to do the MP joint, bring the MPs down, and if your IPs are yet in flexion, then all your fingers are going to dig into the palm. Just imagine you have released this and your fingers are like this comes down and it's just going to dig in. So you can safely release the IP joints. And if you feel that they are, like Dr. Durga had asked earlier, whether they are arthroids or something else, then you could consider putting, what you mentioned is right, you could consider putting pins so that you can distract simultaneously once in the post-operative period. Or you may actually have to do some boutonniere work.
What about the web spaces that you will also release the same setting? First, except
ma'am.
first, second, third, and fourth.
That we would release in a, as a second procedure.
Okay. What are the, principle of release of hand contracture? What are the principles?
Ma'am, the first principle, we need to see that the thumb comes in opposition with all the fingers to get a functional hand.
What functional hand?
So first, web space.
What is your achievement? I mean, what you want to achieve with the functional hand?
Ma'am, the 3 major things like grasping, key pinch, and the pincer pinch.
Yeah, these are the important. Grasp is very important to keep the hand in the grasp position. Other principle?
So the thumb should meet the other fingers so that we get the precision and the key pinch also.
That is okay. That is okay. Now the second
Durga,
one.
time is over.
Okay.
Because moderator time also over.
Okay.
I invite Dr. Bhattacharya, sir.
My time is over, you said. Okay. Why palm is free?
Sir, since first hand is the first defensive mechanism when we are exposed to anything, so dorsum of the hand goes first when we are exposed to any injury, and that is the first reason. And when the dorsum of the skin is thin, so more edema occurs over the dorsum of the hand. And since the physiologic position also keeps the
Ease position.
position of ease, it is a dependent position. So the chances of more edema happening over the dorsum of the hand.
All these explanations explain that palm is totally free. No. Next question is, you said incision and then release and flap cover. Is it possible in this case? Say right hand.
Rivalli,
Incision release or excision release when you're
post
planning
the
for flap.
hand photos.
Will you do an incision release or excision release when you're planning for a flap cover? How do you prevent the bowstringing of the tendons, extensor tendons, while making the release after incision or excision, whatever? Next question is, if this remains for 5 years, what will be the effect on the proximal unburned muscles, long muscles, flexor and extensor?
Contracted, shortened and contracted.
Whatever.
Shortened and
And
contracted.
and will it have any effect on the post-burn physiotherapy, which is essential?
Yes, sir.
So what will be the effect, say, after 5 years if you don't treat? What happens to the muscles proximal to the burnt area, in the unburnt area?
Since the long extensors are not in use, they also get shortened.
Plexus are also not being used practically, isn't it?
Yes, sir.
I own the extensor. They are not allowing the plexus also. So what are the changes which may happen in the unburned flexor muscles proximal to the contracture?
Flexor muscles. Flexor.
I think the time is short, therefore just go through it. Okay. Okay.
We'll give at the end, sir, to explain. Vinita, to panelists and judges and moderators. Any questions from judges? Or by Dr. Venkatratnam, sir?
Pass from my side.
Yes, you can ask, sir.
Pass.
Pass. Okay. If no questions from the judges, we'll go to the third spotter. And at the end, regarding this hand contracture, the panelists will explain.
Stamp meshing.
Dr. Anjana, Dr. Omar.
What are you seeing in this slide?
Sir, the first picture shows stamp grafts spread over a raw area, and the second one shows meshed sheet grafts.
So what do you think has been done? You see the grafts on the third, in the picture in the center on the gauze piece.
What is you think this all process? Madam is asking that. You think
Any one answer, one name?
Yeah.
Early excision and grafting.
Yeah, that is there. And what have you done? You have answered.
Meshing.
No, team one.
Sandwich
Team
graft.
one.
Huh?
Alexander grafting.
Alexander technique of grafting.
So what
Right.
you were giving the answer, team
What is that?
one? What is that?
Alexander technique, we are putting the
Now we'll go to team two again. What is this grafting they are telling about?
Sir, Alexander grafting is a technique in which we spread autografts over
Team
which
two.
we spread the meshed homografts to cover the areas. When there are large surface area of burns with limited donor sites, we can use this technique.
What is the other name of this technique?
Sandwich technique.
So why is it done?
When the donor areas are less and there is large percentage of burns.
No, you can just mesh. You just take the autograft, mesh it widely and put it. Why are you putting the cadaveric skin above it?
What is the indication?
Better take.
Team one.
A lot of raw areas will be there. If it's a large area and we are meshing the graft to cover, there will be a lot of raw areas in the meshed regions to provide
What
cover.
are you meshing? Actually, you are meshing the autograft or the allograft?
Allograft.
Autograft you have put, right? Why are you putting this graft over that? Cadaveric graft.
So can we?
Answer.
Allograft should be meshed, ma'am. We are meshing the allograft, and this is to bridge the gaps between the stamp autographs which we have applied.
Yes, so you are widely meshing the autograft, right? You may do it in many ways. So can you say one method of widely meshing?
Meek micrografting.
Meek. What is the principle of meek micrografting?
In
What
meek
is done in meek micrografting actually?
Ma'am, in meek micrografting, after the autograft is harvested, it is kept in a squares in which we mesh it. We can mesh it up to 1:9 ratio.
So it is very high meshing up to 9:1. Yes. And then?
Ma'am, meek micrograph already covered.
Actually, you are meshing or you are cutting it?
Sir, actually, we'll be cutting it into stamps, but it will be on a prefixed sheets, which after elongating and spreading, it
Where are
occurs
you
as
putting the sheets for cutting?
Sir?
Why are you putting a graft? Why are you putting the sheet of graft? So that
No,
you
sir.
can
I
cut
mean,
it into the pieces.
in meek micrografting, the skin which is harvested is put over a cork. That is the envelope sheet I meant. That is cut into 1:9, which is spread and elongated and spread over the raw areas.
What did you do then after cutting it?
Sir, we have to take the layer out and reverse it and put it, expand it on all 4 directions and then spread
On
it
what
on
you
the raw.
expand it? How will it expand of its own?
Sir, the sheet itself is like that. If we spread it, it will expand.
No, you're first, before expanding, you have to do something. That's what he's asking.
You have to do something before that.
It is kept in the machine which we have to pass that cube in a machine which will mesh it in one direction, and then we have to turn and put it in
Not
another
mesh,
direction.
again, it is to be cut. You have now cut it.
Cut
Right.
into pieces.
Then what will you do?
We have to change the direction so that it is cut in the another direction also, and then it is removed.
Then put over.
Then it is removed from the cord, and this sheet is applied over envelope adhesive sheet, which is stretched and spread over the raw area.
So why are you putting the allograft over it? Why was this technique evolved?
Ma'am, to cover larger raw areas with the autograft, we are putting allograft over it to reduce the intergraft distance and to promote healing of the intergraft distance as well.
And prevent? If the intergraft
and prevent hypergranulation and between the intergraft raw areas and infections.
Yes, so infection and
anything else?
So you prevent desiccation, no? In between, you will prevent loss of water, you'll prevent loss of proteins, everything you'll prevent from that in-between space because you have given a lot of space in between. In the meantime, the homograft actually takes in between and then it will, by the time it separates, you will also have healing from the autograft. Yeah.
So by the time that rejects, it's expected that your bed will have been covered by the expanding autograft. Yeah. So what do you mean by early burn wound excision?
Early burn wound excision
when is it done, the timing?
Ma'am, it is theoretically before 5 days to 7 days after the burn injury happens, and now it is even done within 24 to 48 hours of the burn injury.
After completed of resuscitation, we can do excision, ma'am.
As soon as the patient is stabilized.
You know the person who first advocated it? Huh?
Tangential excision is done by Jansikovic.
Yeah, Yankovic. So she was a lady plastic surgeon from Yugoslavia.
Yugoslavia.
Yeah. Okay. So what is the advantage of this? Why is it? It has caused a paradigm shift in the management of burns, isn't it? What is the advantage of this early excision?
Early excision and grafting prevents, improves the wound healing, reduces the mortality rate of the patients, improve wound coverage. So the complications like infections and other complications in the patients are reduced.
And hospital
What
stay will be
happens
reduced.
first? What happens first when this burn tissue is there? What does it cause within the body?
Sepsis, we can prevent the sepsis by removing the burn tissue and the ongoing infection
Team
by
one?
early excising.
Team one.
The main focus of the possible focus of which can get infected is removed.
So what happens when burn tissue is there in the body?
It is act as a focus of infection where microorganism can colonize and
Leads to
that is much later. What happens? There's a cascade which occurs, isn't it?
Inflammatory.
Yes, so your aim is to
reduce the inflammation.
stop that inflammatory cascade from starting, apart from the other things which you mentioned. And what happens to the wound healing also if you are doing early excision? What is the advantage which you have, which is found in early excision?
Wounds heal much
Wound will heal
faster.
fast.
Team two, yeah.
Wounds heal much faster when we graft the wounds immediately after early excision.
What are the types of early excision? I mean, what are the levels to which you excise?
Tangential excision, ma'am.
What is
Sequential
tangential
excision? In tangential excision, usually indicated in deep dermal burns, mixed thermal burns, and full thickness burns. And we have to go till the viable tissue, that is at the level of punctate bleeding and the viable fat is appeared. We have to stop there. Before that, we have to mark the area where we have to excise it. And before that, we have to apply the methylene blue. And after that, we have to excise the area. We have to start from the full thickness burns too. We have to come to the normal tissues.
What is
And
the
next,
what is the estimated? What are the problems in this?
there will be excess of blood loss.
How much is the expected blood loss for the percentage you excise? And why you are going to earlier? You're doing it at 24 hours. Why now?
For 3% of the total body surface area excised, it is approximately 1 unit of blood loss.
And team two or team one?
Ma'am, and early excision stops the inflammatory cascade, like you said. And if we go for an early excision, even before the infection steps in, we can cover the wounds and get a better and faster healing.
So there's less hypertrophic scarring also in deep dermal wounds if you are able to excise and cover it. How much percentage is excised in a sitting? Is there a rule? Is there any rule or has it changed or what is your this thing? How much
It has changed, ma'am. It was
in our
earlier.
center, we are doing up to 10% we are excising.
And with better, is it still 10 or you can do more?
There are centers going even up till 30 to 40% also.
Yes. So what is your aim of early burn wound excision?
To get the wound bed ready for grafting and to prevent infection. And
that is the advantage is what is you're starting the early excision. You are not able to excise in one sitting.
To go till the viable.
What is your goal?
To reduce the load of the burn tissue.
No, the goal. By when will you aim to excise the whole wound? You have to excise all the
ma'am, within 2 weeks. Before 2 weeks.
Team one?
7 to 10 days.
Yes, you have to plan to complete the excision by 7 to 10 days. And then what is the second type of burn wound excision? One you said was tangential, team two. The other?
Sequential excision, ma'am. It is similar to that of tangential excision. And we have to take...
Sequential is your timing, but I'm asking about the depth.
Facial excision, ma'am.
What is facial excision?
Till the level of fascia, we can excise, ma'am.
Yeah, so what is the advantage and disadvantage of facial excision?
We are losing more of the
deep burns.
dermal elements and subcutaneous tissue.
What are
You're
you
doing it where
emphasizing
you
in
don't have
facial
dermal
excision? What are you
elements,
removing?
isn't it?
What are you removing in facial excision?
Anjana, time is over.
Okay.
We have to go for the moderator questions. I invite Dr. Bhattacharya, sir.
I'd like to know that how do you identify the devitalized tissue in the burn? Mixed type of burn. Somewhere it is deep, somewhere it is not deep. 2nd degree and 3rd degree. How do you identify? What are the methods?
Methylene blue application, sir.
How long you will continue with that? Suppose you have applied, then?
12 hours, sir.
Again, after a few hours, you might, because it's a progressive thing many a times. So, is there any other method which will give you, which will allow you to assess it almost for 36 hours?
ICG dye is being used.
More simpler thing is the fluorescence study.
Fluorescence.
Okay, so it is given intravenous, it is excreted through kidney, and it remains in the body for 36 hours. You can take the part under the ultraviolet lamp and assess the viability. If the area is dark, it is non-viable. If the area is showing fluorescence, it is viable. And this was an Indian contribution, major Indian contribution. Just name that person who used it extensively and who is known for it in the whole world. Indian contribution you must know. We take names of various countries, people. Why not Indian? We have enormous contribution. Very, very senior person. Much senior than us. I can't give more than this hint.
Team 1.
She is amongst us. She is from Chennai.
More than this hint, nobody can give.
Everything has been told.
She's the senior most in burns.
She is the first MCS candidate of
Dr. Mathangi Ramakrishnan, ma'am.
Yeah.
Yeah. So it is her contribution, and that technique is applied to various other types wherever you want to see the viability. If it is flab viability or burn viability or any other tissue viability, this is a very easy and cheap way of doing it. Okay. I think I won't comment more than that. Thank you.
Thank you. Any of the judges would like to ask any questions? Dr. Venkatratnam?
Yeah, I have something. In a moderate degree burn, moderate burn, not this much extensive, but a little bit moderate burn. Mixed degree burn. When you are excising the burn with Humby's knife or any other dermatome or whatever it is, there is a possibility of excising the early young epithelium also, and more blood loss in the freshly healing wound. To minimize that, all those things, only to remove the dead part, eschar part, which is in between like islands, there is a technique. Do you have any idea about the technique? You will use some instrument for that.
We can use a silver graft handle, which has a smaller.
No. This is not a new technique, but not that commonly used in India, but it's a very good technique. Anyway, to save time, in the interest of time, I will tell you. The other team can join. Other team can answer.
Team one.
Team one.
Would you like to answer? I don't think so, sir.
Okay, they have not opened. Anyway, I'll
Yeah.
give the answer. Did you hear about Versajet?
Yes, sir.
Tell me what it is. Then
Sir,
why you did not
Versajet.
tell before? You lost the marks. Okay, go ahead. Tell now.
Sir, Versajet is a kind of hydrotherapy where we have the probe. Over the machine, we connect the saline, and through this probe, a thin jet of water spray comes, which will excise the wound in a much a lesser depth. It is 0.005 mm of depth compared to the regular grafts which we take of 0.012. So
Have you
we
seen
can
that?
preserve.
Have you seen that?
No, sir.
It is straight or curved or any other shape.
Sir, the tip has a slight curve. That is what we have seen in the picture.
Yes, angled, slightly angled. Okay, angled
It was
with holes on both the sides.
so
the
to suck the
water jet flows from one hole to the other with
Yes,
heavy force.
Yes.
That is called Venturi effect.
Venturi. Yes, sir. Venturi.
Venturi effect. Then that will safely remove only that dead eschar, which is in the form of islands in between the healing areas. So the healing areas and a little bit of epithelium which came from the depth in those areas also is safe. Only this part you will remove, and then if necessary, you will cover it with something, graft or flap, or otherwise you will allow it to heal. Okay, over.
Thank you.
As all spotters are over, I invite the panelists whom I interrupted in the discussion of the hand contracture. Kindly put your how you address this case. Dr. Vinita, Dr. Durga.
I would, yeah. So as I mentioned, the first decision we have to take is which hand would we like operated. In this case, both the hands look very, very similar. So, but yet in case the patient feels that she would like any one specific hand to be operated first, because we really don't know what is the actual joint function. We can do it accordingly. We can do that hand. Now, I also think that it depends on whether there is already bony arthrodesis in any one. So I feel that if there is, lesser inner injury in one, I would probably like to do that first because I can get that hand back into function earlier. Now, in terms of surgery, I would like to do an incisional release in this patient, release the MP joint, bring it down. Also do the IP joints. I'm not very sure whether there is I can't really make out from this whether there is a direct intrinsic damage on the volar side, but I expect that it could be there, in which case that I will have to release the intrinsic flexion contracture again with an incision release, get those fingers straight, put in pins for the MP joint, put in pins for the IP joint, get the position similar to what the students mentioned, get the MP at 90 degree and IP joint straight, bring the thumb out and get the, basically try and give this position as far as possible. Now everything depends on what is it that is exposed. 90% of the time I can get away with grafts in most of the cases. The number of flaps I put are lesser for the dorsum. If needed, you can put in a flap, which means that we should have obviously pre-counsel the patient always, get the patient ready. If you think that you are fine with the free flap, I would be happier with the free flap instead of, because it's easier to position and keep it ready. Else you would need to go in for a groin or something like that. I would also do the syndactyls at the same time. That would be my position. Remove the pins after 3 weeks and then start the exercise protocol and with splints. Since dermal substitutes are available now, if possible, I would like to put a dermal substitute on the MP joint if I'm going ahead with the graft. and the stability of the grafts are better. The stability of that everything that is there is better. So I think that our rehabilitation is slightly better with them. Once we are settled with this one hand and you get some part function, we can go ahead and start operating on start a similar procedure on the other hand. That would be my plan.
I slightly differ with ma'am. I would like to, release this dorsal contracture along with because skin is very unstable along with the skin. So I plan to release dorsal so that the MP should be flexed almost about the 70 degrees and the web space to be released, maybe the skin and maybe requirement of adductor polysis some part. Then after that, because I think this buttonate deformity I won't be able to address in first setting. So, after either a groin flap is okay to make the first web space and the dorsal cover along with the MP, because this release will go up to the PIP joint, just proximal to the PIP joint. So we have to cover MP along with the dorsal skin of the PIP just proximal to the PIP joint. Then I have to go for the capsulotomy and collateral release also to make the position in the MP flexion for about 70 degrees. Then in the second stage, I will see this buttonate deformity. This appears to be because dorsal skin is not healthy. We cannot reconstruct some lateral band, something like that. We will go for the orthodesis from the medial to lateral 25 to 50 degree of the flexion. That is my plan. And I can say one thing is that because the hand contracture, our goal should be very specific because we have to give the grafts up to the graft function so that patient can do and use. This is for the severe deformity. And second is slightly for the aesthetic one, which is also important, but we will not consider in this case. But the second goal is the aesthetic. And because we have to release all these joints and, contracture to make their position as original as possible. And all these joint reversal of the joint, we have to make in position as far as possible. So these should be the goal, functional, aesthetic, and to make all these, structures in their place.
Finally, what result we will get will also depend on how old this contracture is. Right now, I can't really make out. It is not exceedingly fresh because I'm not seeing a lot of redness, but also it may not be very old. So if it's not very, very old, then what Bhattacharya sir mentioned basically depends on what will happen to the tendons. If it's very old, then tenting happens. I always do a Z-lengthening of the tendons, or I should say I do a lengthening of the tendons. And if a lengthening of the tendons is done, then we have to also think about how we are going to give cover. Extensor tendons especially always need lengthening in this kind of a severe deformity. So there are multiple things which will have to be done. If we are going ahead and put in a flap, then occasionally there are people who will even cut that tendon if it is so far. But whatever the length of shortening, whatever be the length, I tend to always lengthening and suture it. That is, you cut one side, give a straight length, and then it comes. You actually get function also in these joints then with the same tendon. And I think where a hand is concerned and all contractures are concerned, everybody has their own way. I tend to be a bit more aggressive.
Dr. Bhattacharya sir will give the final comment.
Yeah, I'm waiting to hear sir's thoughts.
I
Thank
agree.
you, panelists. I invite moderator, sir.
Yeah.
Yes, sir.
Yeah, I agree with the principle what just now Dr. Venita said, that it is actually a modified Z plus T and it is very effective.
Yes.
Even for larger tendon like tendo Achilles, I learned it from somebody, extremely useful. But the moment you handle the tendons, you require a flap. And if you are little careful and little daring, you can feed the flap to the webs by making them multiple prong. We have done it. Gradually, as we become senior, we try to do it. If possible, do it and see that it works very well so that you don't have to release the syndactylized flap again. You can feed the flap into the web. That is one. And the answer which question which I asked, that what is the long-term effect on the proximal muscles, both flexor and extensor, is that that if it is more than certain period of years, maybe 2 years, 3 years, 4 years, 5 years, then there is disuse atrophy. And we have done extensive study on this. We have published it also. And lot of atrophic changes occurs in the muscle. And clinically, if only one hand is involved, other hand is normal. And if you measure the circumference at different level of the forearm, you will find that there is reduction in the circumference of the affected limb, showing that it has a atrophic changes to the underlying muscle. Now, what is the clinical implication? After release and doing all joint surgery correction, we keep on insisting upon the patient to do physiotherapy more and more and more. But if the muscle is partially atrophic, the duration of exercise required to recover completely will be more. And therefore, there's no point in coaxing the patient. We must understand that the strength of the muscle has reduced because of atrophic changes. That is the scientific clinical explanation of long standing. So when if only unilateral hand is involved and the other side is a control, if you do EMG study or even biopsy, a small biopsy of the muscle, both will collaborate with this finding, and that will explain what happens to the muscle proximal to the burnt area due to disuse. I think I have tried to explain it.
Thank you, sir. Any doubts from the PGs? Participated PGs are in audience. Anybody would like to clarify your doubts? Eminent, experienced teachers are in front of you. Kindly put your questions. Because I think it's well covered and explained by the panelists and moderator and seniors. I invite the judges to put their comments. Actually, there are only 2 judges in audience, Dr. P.V. Sudhakar sir and Dr. Sanjeev Uppal sir. So I invite Dr. P.V. Sudhakar sir.
Yeah, thank you, Dr. Lakshmi. Wonderful effort and rather an exhaustive one today. And I congratulate both the teams for coming forward to participate in this particular program. And I think this will give them a lot of confidence in future. And 1 or 2 quick suggestions. Number 1 is whenever they are examining a particular patient, they are showing a picture is being shown, they are telling their diagnosis in piecemeal, which is not appropriate. They have to take 1 complete minute to examine, to see the picture from top to bottom and spell out the diagnosis of every part. They cannot concentrate only on a chest, only on the hand, or leaving behind the face, so on and so forth. They have to be very comprehensive when they are going to tell the diagnosis. That is comment number 1. Number 2, most of the times they are saying that we can do this and we can do that and all. It is the patient that is given to you. It is always appropriate to say that I will do this way. That gives you more confidence. This is the way I do. So this is another thing that they have to follow. So most of the times, that all this comes out of repeated exercises of presenting cases. So very good. Hearty congratulations to both the teams for having participated in this and tried your best in front of a huge number of audience, particularly the teachers like Dr. Bhattacharya and all. And at the end of the session, I wish to announce that the Gandhi Medical College team will go to the next level. They are the winners today. Gandhi Medical College, that is the team number 2.